Good afternoon and welcome to this NHS West Yorkshire Integrated Care Board meeting. We're here in Wakefield today and as you can see around the room we have a number of representatives across our health and care system and our broader partnership to come and discuss a number of things today. Our theme for today is particularly looking at winter planning and delivery, and particularly how we are supporting services and working with services to support communities during this very challenging winter period to offer safe quality care. There are a number of things on the agenda today, very much looking at our integrated performance report, our board assurance framework, and for people watching that means that we are making sure that we have oversight of risk in our system and making sure that we're mitigating risks and making sure, as I said, we continue to offer safe quality services. I'm going to ask people around the table to introduce themselves. It's always helpful and courteous in the room, but also for people who are watching live or on record afterwards as well. So Fatima, would you please start us off and introduce yourself and explain your role on the board today?
Afternoon everyone, my name is Fatima Khan Shah and I am the West Yorkshire Inclusivity Champion.
Hello, Sarah Munro, Chief Exec, Leeds and York Partnership Trust, here as Sector Lead for Mental Health, Learning Disability and Autism.
Hello, I'm Brendan Brown, I'm the Chief Executive at Calderdale and Huddersfield and I'm the Sector Rep for the West Yorkshire Association of Acute Trusts.
Hello, I'm Karen Jackson, I'm the Chief Exec at Locala and I am the Sector Rep for Community Services in West Yorkshire.
Hello everyone, I'm Harris Sultan. I'm on the Next Director scheme on the ICB with the remit of Citizens and Future Generations.
Good afternoon, I'm Becky Malby. I am the Non-Executive Member for Future Generations.
Good afternoon, I'm Robin Tuddenham. I'm the Place Lead for Calderdale. I'm also the Local Authority Chief Exec for Calderdale Council.
Good afternoon, I'm Beverly Geary. I'm Director of Nursing for West Yorkshire ICB.
Good afternoon, I'm Melanie Brown, Deputy Place Lead for Wakefield, representing Joe Webster today.
Afternoon all, I'm Anunshu Chatterjee, Non-Exec Member for the Board, looking after finance, digital performance and transformation.
Hello, Anthony Keeley. I'm Director of Planning and Performance for the Integrated Care Board.
Hello, I'm Jonathan Webb, Director of Finance and Deputy Chief Executive for the Integrated Care Board.
Hi everyone, my name's Ian Holmes. I'm Director of Strategy and Partnerships and Deputy Chief Exec for the West Yorkshire Integrated Care Board.
For people who regularly are aware of our meetings, Rob Webster, our Chief Exec, is on leave today, so Jonathan and Ian are acting on his behalf today and taking on that dual role of Deputy Chief Exec. I will come on to my role in a minute, but I'm going to hand over to Laura now.
Good afternoon, I'm Laura Ellis, Director of Corporate Affairs.
Good afternoon everybody, I'm Majid Hussain. I'm a non-exec member and I'm the lead on people, inclusion and freedom to speak up, guardian, etc.
Hello everyone, I'm Carol McKenna. I'm the Place Lead for Kirklees.
Hi everyone, my name's James Thomas. I'm the Medical Director for the West Yorkshire Integrated Care Board.
Hi, I'm Tim Riley. I'm the Place Lead for the City of Leeds.
Hi, I'm Kim Shuttler. I'm the VCSE Sector Lead.
Hello, I'm Kate Sims. I'm the Director of People for the West Yorkshire ICB.
Hi, and I'm Jo Madeley. I'm a non-exec member and Chair of the Audit Committee.
Hi, I'm Mel Pickup. I'm Place Lead for Bradford District and Craven and Chief Exec of Bradford Teaching Hospitals.
Hi, I'm Hannah Davies. I'm Chief Exec at Health Watch Leeds and I'm here on behalf of the 6 local Health Watch.
Hi, I'm Lou Auger and I'm the Deputy Director for Planning and Performance for West Yorkshire ICB.
Thank you everybody for introducing yourselves. And my name's Cathy Elliott. I am Chair of NHS West Yorkshire ICB and I'm Deputy Chair of our Health and Care Partnership. As always with our NHS West Yorkshire Board meetings that currently happen every 2 months in public, we work to make sure that we're demonstrating the 4 purposes of an integrated care system that's around improving the outcome in population health and healthcare, very much what we're going to talk about today, tackling inequalities in outcomes, experience and access to care. Again, we'll touch on that today and very much we want to take that forward as themes into our future board meetings. Enhancing productivity and value for money. We'll be talking a lot about finance today and the financial pressures in our system, and the NHS supporting our broader social and economic development, which we talk about here, but we also talk about in our West Yorkshire Health and Care Partnership Boards, our Integrated Care Partnership, including our last meeting on the 5th of December. So, can we just take the apologies, please, Laura?
Thank you. Yes, we have apologies from Rob Webster, Richard Vortree, Joe Webster and Mel Brown is deputising. We're expecting Rachel Spencer-Henshaw. She's just going to be a little bit late arriving. And then Sarah Munro and AC need to leave at 4 o'clock. Thank you.
Thank you. So the next item is declarations of interest. This is something that we always do as a public-facing and public-serving board. Members of the public can find out about our declarations of interest on a live portal that we have online. We also ask at the start of every board meeting if anyone has any conflicts of interest, perceived or actual, in relation to today's agenda. And can I look round the table? Does anyone have a declaration in relation to today's agenda? Laura, do you want to give an overview? Thank you.
Thank you. It won't go around everyone, but we're just recommending that anyone who's employed by the ICB declares a direct financial interest in the operating model update that's within the Chief Executive's report. It is for information only, so we don't need to take any further action. Thank you.
Are there any other declarations of interest around the table today? No? Thank you. What I would say as part of best practice, and Laura has some training on the way for us as board members in terms of a new training module on conflict of interest, we ask you that sometimes in the moment of a discussion as well to declare any perceived or actual conflicts of interest. Okay, thank you. So we now move on to the minutes of our last meeting. If you remember, in November we came together, we had a focus on session on primary care, meeting a number of colleagues in the morning in relation to delivery of primary care in places. So, colleagues, are the minutes of the meeting an accurate record of the meeting that day? Yeah, I'll take silence and nods as a yes, which is great. Thank you very much. Laura, would you just talk us through any key points from the action log, please?
Thank you. Yes, just running down in order on the action log, which is page 18 for those who've got the full pack. The first open action is number 5, which is around the minutes of a previous meeting. So just to confirm that we have that amended wording now from Harris so that we can close that action. The next one isn't yet due, and we're proposing that we close action 13. Action 14, which is still open, we'll leave it open for the time being, but Ian and I are due to meet in the next few days in terms of getting those risks relating to primary care onto the risk register as we launch the new cycle. And then the final one around winter planning is proposed for closure. Thank you.
Great. Thank you, Laura. And the action for me particularly was a discussion with colleagues in Wyatt about having a reiterated role for the ICB Chair and Chief Exec in connecting with that provider collaborative, which I've recorded in my Chair's report today. Are there any matters arising at all from the minutes of last time when we met in November that you feel are not on the agenda today but you'd like to raise? Is there anything there? No? No? Okay. One thing I wanted to just remind us of, and this is a workload for particularly for Ian and Carol, is that we agreed to have an update from the Fuller Delivery Board around primary care developments, having looked at primary care as one of our focus on topics in November 2022, then November 23, and to have a follow-up. I don't know, Ian or Carol, if there's anything else to share, or we just note that update will come next month, in March?
Not at this point. We'll bring something back to the meeting in March.
Thank you. So we then move on to public questions. We haven't had any public questions this time in relation to today's agenda. I want to continue to reiterate that we always welcome questions from members of the public and staff working in health and care in relation to the agendas for our meetings. We receive them regularly for this meeting, the NHS West Yorkshire Integrated Care Board meeting in public, and we also receive them for our West Yorkshire Health and Care Partnership Board as well. So we're always grateful for them. The opportunity to ask questions for our next meeting is around mid-March time and will be available online and promoted on social media. Okay, so we're going to move on then to item 5, which is my report as chair. One thing I wanted to mention before I give you an overview is today's board meeting is the last for Harris Sultan, who's been with us for 18, 20 months or so, as on a Next Director placement. If you don't know, NHS England run a programme called the Next Director Scheme to encourage people from diverse backgrounds to come and get an experience in being a non-exec director and to learn about the world of public boards and governance. And Harris, if I give you a minute, is there anything you'd like to say today at your last board meeting?
Oh. I think just gratitude to all board members and the staff across the system. But really, this has been my first non-executive role in the NHS, and I've been really warmly embraced and felt really comfortable. The last 20 months has been an incredible journey. I never thought I'd contribute the things to do and the mutual learning through so many conversations with people around this table. And as I transition to new roles, I do carry around the insights I've had, and me and Fatima named it earlier, the West Yorkshire way. I've gained so many lessons, and I'm confident these lessons will continue to shape my career into the future. So thank you, everyone.
And thank you very much for your contributions over the last few months, so particularly as we set up as a new statutory body. For those of you who are members of our ICB Remuneration and Nominations Committee, Harris came along to our last meeting earlier this month to contribute and share his experience. Majid chaired that meeting for us, and I'm pleased the committee is supportive of exploring another placement, building on the learning that Harris has shared with us as well as our own, in making sure that we've got diverse views and backgrounds around our board table. So thank you, Harris. Good luck. You're with us till Friday, so there's still a few more days to ask all these people around the table to share their experiences. But thank you for your contribution. The other thing as well I wanted to share is, as you know, we try and get out and about and be visible, engaged as board members. So this morning we're grateful to our colleagues at South West Yorkshire Partnership Foundation Trust, who shared with us their work on mental health inpatient services. We met a number of staff. They kindly showed us around appropriate parts of ward areas without disrupting patient care. And it was great to have the opportunity to meet them. And also thank you to Jo Webster, Place Lead for Wakefield, who particularly talked through the ways in which services are connecting together, particularly how mental health and physical health is connecting with social care and housing. And it's not a simple thing, and it's built on a great foundation of partnership, working, collaboration. But it was really helpful. So we'll be sharing that learning. And colleagues who went on the visit today, you may hear that referenced as we go through today. The visit also gave us more learning as well to inform the next cycle of our board visits programme, and we'll be looking at that to align with our new governance cycle, which I'll hand over to Laura in a moment to talk about. But it's always about making sure that we're visible and engaged in our system. So in terms of my report, some highlights from me. There's some information there about the partnership board, and there's lots of information online about what we talked about at the last meeting. I really want to highlight the Chairs and Non-Executive Development Working Group that has recently been set up, and thank chairs, non-execs, company secretaries from across the 10 providers in our system, across our 5 places, for giving their time and their constructive criticism on how we can work together to support the development for our current chairs and non-execs on provider boards, as well as bringing the next generation in, and that includes learning from Harris's placement with us and also the Gaten B. Sanderson Insight Programme. So there's an update on that. There is also some information there on our board's continuing commitment to equality, diversity and inclusion, on our reporting recently to the Remuneration and Nominations Committee, and making sure that we're complying with new requirements from NHS England as well. I just want to hand over to Laura to talk to you very, very briefly about the new governance cycle coming in for our board, and also just a highlight on the complaints. So for the first time, you've got in my report a highlight of complaints across the system that the ICB have involvement with. So Laura, to you.
Thank you. Yes, I'll just give a very brief update around the governance cycle. We will be bringing more details to the next meeting. So as board members will be aware, we have been spending time reflecting on our current governance cycle. We're around 18 months in now, and it's given us a chance to reflect on that, to make sure that we are as agile as possible in terms of the way that we make decisions and have the ability to make good decisions in a timely way. So the main way we've been looking at this is around the flow of meetings to make sure that information flows throughout the governance cycle. We're a fairly complex organisation, a complex system, and we are looking at reviewing that cycle. So we will have fewer meetings, but they will flow better. So we will be able to give more assurance as we work through up to the board, if you like. The board's the end point, but working backwards through place committees, the West Yorkshire Assurance Committees, and down into place subcommittees, for example. So we will bring further detail into the next meeting when you'll see a calendar of dates for the year ahead, and I'm happy to talk to anyone in more detail if they want to around the governance cycle.
Great. Would you just talk about complaints?
I can talk about complaints, yes. Excuse me. So I think it would be fair to say that lots of people have a very positive experience when they come into contact with our services, but we do know that unfortunately things don't always go as well as we hoped, and it's important that people can contact us to let us know when this happens. That gives us an opportunity to be able to help them, but also to learn to try and put things right for next time. So the Quality Committee keeps a good overview of our complaints. We bring a complaints report in detail into there, which contains details around the themes and trends that we're seeing at the current time. And I think that's within your report, Cathy, in terms of the current themes or hot topics, if you like, around what people contact us about. It would be fair to say that we are seeing an increasing number of complaints. That's not unique to West Yorkshire. We're seeing that across nationally, and the Quality Committee are keeping a close eye on that in terms of what that means for us. We have just taken the opportunity to highlight about making sure that we are respectful of colleagues. So hopefully we're always respectful with people who contact us to make complaints, but we ask the same for our colleagues as well. Thank you.
Okay, and I've just on complaints, that's prompted some questions. I've got some other updates, but we'll go on to that point. Hannah, do you want to come in, and would you introduce yourself just to remind people watching who you are, and then we'll come to you, Fatima.
Hi, yeah, I'm Hannah, I'm Chief Exec at Healthwatch Leeds. Yeah, and you said it, Laura, but I suppose complaints are a really useful mechanism for us as a health and care system, and actually I think linking it to around abuse of staff is a bit tricky in a way, because actually most people make a complaint in a very good and respectful way. So I just, I think that message is we want to hear people's feedback, whether it's via a complaint or whether it's getting involved in the patient participation group or whether it's getting involved in Healthwatch activities, or we want the people of West Yorkshire to actively work with us to get things right and share their experiences. So I just wanted to highlight that. And also the ICB complaints system, people complaining, is just one way that people give their feedback, and it'd be great to work to think about how we hear that totality of where people are kindly sharing their experiences across health and social care.
Thank you, Hannah. I think it's something we can talk to our colleagues working on involvement, as well as yourself and with West Yorkshire Voice as well, that actually all feedback is very helpful, positive, negative and neutral, and there are lots of different ways, particularly in the NHS, you can feedback. So we'll take that as an action to come back, and particularly cross-referencing complaint themes with Healthwatch intelligence as well. I think it'd be really helpful. So something our Quality Committee as well as our involvement team can pick up. Fatima, would you introduce yourself again?
Yes. Hello, Fatima Khanshah, the West Yorkshire Inclusivity Champion and also the chair of the West Yorkshire Strategic Race Equality Network. It was just in reference to the work that you've been leading on, Cathy, regarding the sort of diversity of our chairs and non-executive directors. One of the overwhelming bits of feedback that we've had from the Strategic Race Equality Network was a commitment to ensure that we're thinking about succession planning within our executive colleagues as well. And I know that you've mentioned within your report about the work that we're doing with our executive leaders to ensure that EDI is embedded in everything that we do. And it was just to sort of assure people that that is the case, that there is an opportunity to do some cross-referencing and cross-learning. The second point was about what's different about this particular working group and all the ones that we've had before. And it was just an opportunity to plug that we have got some new voices, some new leaders joining the team, and also trying to, where we can, influence beyond the realms of West Yorkshire too. So the work that we're doing with recruitment agencies in particular, I think, is really important to emphasise that this isn't just a remix of the same song. Hopefully things will be different as a consequence.
Thank you, Fatima. It's really helpful. I'm grateful for you supporting the working group, and also to the CCOL group as well, who work nationally, but we've got so many CCOL group members who are particularly supporting more people from ethnic minority groups to come in to be non-execs and chairs. So I'm glad that they're working actively with us. And then trusts are also influencing recruitment agencies in working with CCOL group and others as well. So more to be done, I appreciate. Thank you for that. Harris.
Just on the complaints, linking into what Hannah says, the formal complaints procedure tends to be for people that are more vocal, and there's a lot of underrepresentation from more marginalised groups who can't navigate the intricacies of an NHS complaints process. So what strategies does the ICB have to ensure to capture people who are from these groups, and what innovative and less traditional approaches are used to engage individuals who aren't inclined or utilise the formal complaints channel?
Laura, I think, and then Hannah, do you want to come back in? Thank you. Laura.
Thank you. I mean, I can speak in terms of the ICB complaints approach. Hannah, I'm sure, will bring some of that wider perspective in. It's a really good question, Harris, and actually it's something that I'm particularly focusing on. It's one of my objectives for the next few months in terms of making sure that our complaints process is as open and inclusive as possible. So I probably can't give a full answer now, but to say, good question, definitely something that we are going to be working on.
Hannah.
Yeah, I totally agree. A really good question, Harris. We know that a lot of people wouldn't use a complaints process, so you know it is just one indicator to understand people's experiences, and I think that's why bringing in those wider mechanisms is really important. We at Health Watch particularly want to focus on hearing people with the greatest health inequalities. West Yorkshire Voice has a focus on hearing inequalities, so that's why it's really important not just to look at an ICB complaints process.
Thank you, Harris, for that question. I think, Brendan, do you want to come back in? Would you introduce yourself?
Hello, Brendan Brown, the Acute Sector Lead for the West Yorkshire Association of Acute Trusts. I think the thing here is we get caught in the process. The clue to this is ask the complainant what they want to do, and I think that's the work we're taking across organisations. We can get caught up in the mechanism and the escalation. Ask the complainant how they want their complaint to be responded to. That's what we need to. I think that's the art of the possible. I think we can get caught up in process, which is often where it goes wrong.
Thank you very much. And I know there are people that working in a variety of different teams and services. We met a number this morning at South West Yorkshire who spend a lot of time in making sure that a patient's experience is a positive one. We heard a lot this morning about working with service users to make sure the environment and care is tailored to them, but also listening to critique and criticism as well and concerns. So AC, and then Tom, you can come in after that.
Thanks, Kathy. Just an observation for Laura in terms of when you're looking at this overall approach, it will be useful to also explore that can we resolve it before a complaint is made. So in terms of how do we address ongoing feedback and incorporate it into sort of usual operational activities so that it doesn't translate into, I'm assuming that you will do that anyway, but it will be useful to highlight and sort of do that. I also have a comment around the governance, but we'll come after this.
Sure, yeah, I'm Tom Reid and I'm the Chief Executive of Leeds City Council. Just having had experience of introducing the Freedom to Speak Up Guardian into the Council over the last couple of years, one of the things that we've found really important is to make sure that we don't try and get one process to duplicate another. And so, yeah, I think because we're a network of different organisations, there is a good chance people will have been down a complaints route already. So I think it's really important sometimes to think about, make sure that all that information is available, and that's not to say that because one complaint route has been tried that another shouldn't, and there may be occasions where this, the ICB can take another look at something in maybe a slightly more independent way. But I think there's a danger sometimes that we don't want to send people down a completely similar process, taking a lot of time, that will just end up with the same answer. And also, so I'm not quite sure about the Ombudsman arrangements for the health side, but for us, the next recourse is the Ombudsman. So that's when I think we need to, iterate as we go on this one and learn as we go a bit, giving people the maximum opportunity to get the points across, but also get the outcome, as has just been said, that will help everybody. And just another observation, picking up Fatima's point, there has been quite a closeness at times with the EDI agenda that we've been trying to do, trying to move forward. So I think getting that connection and getting that sort of learning at this level on all the work that we're doing on EDI, I think is really important for us. And again, trying to make sure that that adds value rather than duplicates things that are happening in the organisations themselves. And a bit of benchmarking, a bit of understanding of staff surveys, of customer surveys, between our different organisations would seem to be a good thing that the ICB might do.
Thank you, Tom. So there's the long to-do list there for you, but I think that's incredibly helpful in making sure that things are simple, accessible, they're cross-referenced. I know when I've dealt with complaints myself, there's something about making sure that we're trauma-informed as well. People are distressed about situations that they've been in, which is sometimes why they're coming to certain people and certain levels. So thank you for that. Karen, do you want to come in? And then I just want to finish the report.
Yeah. Thank you. Just, sorry, I'm Karen from the Community Services Network. Just to say that we're not all statutory bodies in the room, so it's important to recognise that there are complaints that are received by other organisations, and they are handled in a very similar way. So I just thought it was worth saying that we're all involved in this process, and it's important that all our services, statutory bodies or otherwise, are learning from and to the same standard as. So thank you.
Thank you. Well, I invite you all around the table to take that away in how we're learning and making things accessible and simple. But I think that's a helpful discussion. Laura and I wondered if we might end up having a discussion on that. So thank you. The other last few points on my report I particularly wanted to share is just welcoming some new leaders into our system or into new roles in our systems. So Selena Douglas has been confirmed as the Leeds Community Healthcare Chief Exec. She will join us, I understand, I think it's March time. Colin Lynch is the new chair at Locala. He was a non-exec director there, but has now become chair. I know he was at the Community Collaborative session yesterday contributing. Peter Redding was confirmed yesterday as Yorkshire Ambulance Services substantive chief exec, and the recruitment for Bradford Teaching Hospital's chair is live at the moment. And just on reflecting on those people who've joined us, Selena, Colin and Peter, they all come from outside West Yorkshire, and so it's great to bring some different perspectives into our work as well, but complementing the West Yorkshire way, I appreciate, as you were talking about earlier as well. So thank you. The other thing I wanted to put on record is that the West Yorkshire Association of Acute Trusts have confirmed and nominated Brendan as their substantive board member to this board. Brendan very kindly took on an interim role when there were leadership changes just over a year ago, so we finalised that yesterday we did that. So Brendan, thank you again for agreeing to stick with us. We must be doing something right, so I appreciate you. Continue to give your time and contribution to this board. Thank you. And are there any other questions on the chair's report? There's quite a lot there today. Majid.
Not a question, but just a couple of questions. You mentioned new people starting. We've got a new Freedom to Speak Up Guardian for the ICB starting this week, so do say hello to them if you come across them. And a couple of points what people mentioned, leadership objectives. So through REMCOM, we've had a number of discussions around leadership objectives, but what we're very keen on doing as we move forward is have impacts and outcomes next term. So we see a real difference in terms of equality and inclusion, particularly. And then just one point around complaints. Complaints is linked to trust and confidence. So I think the broader piece around engagement and stuff needs to work on building and trust and confidence, so people are confident to come forward with a complaint in an accessible manner. Thank you.
Thank you, Majid. And just to put on record, we'll have Kate Sims is going to lead a Freedom to Speak Up Guardian report for us at our next meeting, which I know Majid is our non-exec champion for that. Are you going to support? So it's good, Tom, to hear about the work that you're doing in the local authority world, and we'll hear more about that at the next meeting. Jane, did you want to come in? Would you introduce yourself, Jane?
Yeah. Hi, Jane Madeley, non-exec member and chair of Audit Committee. I just wanted to look at paragraph 5.4 in terms of the data around public engagement, IC board live stream stuff, which I think is really interesting to see. But it's really difficult to judge kind of how we should feel about that as a board, and bearing in mind we are thinking about the governance going forward. That's not just about sequencing of meetings, but how we conduct and what business we conduct here. So I wonder whether it'd be good to get a sense as to what we see in other organisations in terms of that level, and I don't know whether we are able to get any feedback from those who have dialed in and seen the streaming of the meetings. It'd be really interesting to kind of hear whether it matches up against what they expect, or and how we bridge any gaps if there are things that we could change. So it'd be just useful to get some more information later on that. Thanks.
Thank you, Jane. We've reported on this once before, and at that point we had data from a number of other northern ICBs so we could compare and contrast. So our viewing figures look positive if you think that a large number is a positive thing. But we'll come back to you on that. And Karen Coleman, who's our Associate Director in the ICB who oversees this, we can take that as an action and follow up, and we can do some comparisons as well. And actually I had a query from a Provider Trust Chair in relation to our partnership board as well, because we do live stream those meetings 4 times a year, about what the level of engagement of that is as well. So we'll come back to you on that, making sure that everything's value for money as well as fully accessible. Are there any other questions? AC, you wanted to come back?
Thanks, Kathy. Just on the governance cycle bit, I just wanted to start by saying thanks to Laura. Last summer in the board development day, we had a conversation around the operating model in which we made a commitment to reduce and optimize the number of meetings we have. The principle being that more meetings we have, there is a lack of clarity in terms of decisions and functions. So I think this is the right step forward. And we had a good conversation before Christmas around this. So looking forward to the paper. Just one sort of plea would be is, as we do reduce the cadence and improve the flow, the clarity among the system committees in terms of how they utilize existing mechanisms, including the AAA reports, and how we standardize is of vital importance, because otherwise we get less opportunity to collide. So the other thing that we also looked at is around sort of eliminating duplication of conversation and intervention. So if those things could be brought out clearly in terms of in the paper that you bring forward in March, would be really, really valuable for colleagues across the table.
Just to say that absolutely we can pick that up, and we will be spending time at the February development session with the board, particularly focusing on that flow and assurance and, for example, the place committee AAA reports and how we see the flow, as well as the West Yorkshire committee. So we'll pick that up in more detail.
And if anyone's observing this meeting, this is important to make sure that our governance, how we do risk management across the system, is agile, it's value for money, it's the best use of time, as well as we always have oversight and insight in what's going on. So thank you, AC, that's really welcomed. Okay, so I'm going to move us on now, if there are no other comments and questions, over to the Chief Exec's report. So Ian, in deputising for Rob today, you're going to give us an overview of the report.
Yep, thanks Cathy, and hi everyone. Ian Holmes, Director of Strategy and Partnerships and Deputy Chief Executive. So you've got a comprehensive report in front of you from Rob, which describes the key developments and issues since the last board meeting that we had in November. We've also shared with you the Chief Exec's report that we took to the Partnership Board in December, which describes some of the more wider partnership issues we've been working on. I want to start by providing an update on the response to industrial action. So you'll be aware that the Junior Doctors Committee of the BMA called 2 periods of industrial action, one before Christmas and then a 6-day period of industrial action in January, starting on January the 3rd. And the first thing to report really is that the strikes passed off without any immediate serious incidents, and there were no requests for derogations from providers across West Yorkshire. It's important to note there's a huge amount of work went into preparation and oversight and management of those 2 strike periods across all providers, all NHS providers and partner providers in the system, as well as the team in the ICB led by Anthony Keeley. We received a letter of commendation from Richard Barker, the Regional Director from NHS England last week, providing really positive feedback on how responsive and effective our response had been across West Yorkshire ICB. So huge thanks to everyone who was involved in that at a really difficult time of the year. I guess the wider point on strikes, and we've had over a year of industrial action now, is the longer term impact. The longer term impact on staff who are often put in a difficult position, have to make difficult decisions around taking strike action. There's the financial implications. It costs us money to respond to industrial action that Jonathan will get on to, and really importantly it delays care. We can't do as much planned work during periods of industrial action because the responses to the immediate pressures around urgent emergency care, and we know that the impact of industrial action on waiting for planned care, diagnostic activity, routine activity is significant, and that is something that we'll need to manage into the next year and the next planning round. The strike coincided with what is traditionally the most challenging time of the year in the NHS. We're right bang in the middle of winter pressures, and the second period of industrial action coincided with that. I guess the headline across West Yorkshire as we are today is that the pressures are significant across all parts of service, primary care, community care, acute services, mental health services and the ambulance service. But things are relatively stable. I think it's fair to say the ICB has been at Opal level 2 pretty much consistently since about Christmas, and most providers have been at that level with some variation as well. So it feels really challenging but relatively stable, I think, is the message. We understand from public health colleagues that we're close to or at the peak of respiratory infection. You sometimes don't know that you're at the peak until you've slightly come down the other side, but we think the peak is likely to be about around this week, so we're not expecting things to get significantly worse as a result of that in the coming weeks. But as ever, we remain vigilant and we're working really hard to support the system response during the winter period. There's an item later on the agenda that Anthony and Lou and place leads are going to contribute to talk in a little bit more detail about the specific pressures and the response in places. It's worth mentioning as well in the report that vaccine uptake among staff and citizens in West Yorkshire has been lower than it has been in the past for both COVID and for flu. This is a national trend which is also playing out in West Yorkshire. And paragraph 2.12 of the report describes the work that we're doing in response to that, led by James as the SRO for vaccines with colleagues across places. You remember that in the last board meeting that we had in November, we had quite a detailed conversation about 23-24 plans and finishing off the current financial year in terms of the planning process. And that was following a letter from NHS England on the 8th of November, which made available nationally a further £800 million. We completed that planning process. We did a really rapid process to assess plans, develop a new financial position in response to that additional money, and submitted those plans into NHS England. As a result of that process, we've made some minor changes to the trajectories and targets that we're looking to deliver across the system. And paragraph 2.29 describes those, and again we'll pick those up a bit later in the item on winter and planning. In terms of planning for next year, we're in a slightly different position to what we sometimes are, in that we have not received the detailed operational planning guidance for 24-25. This usually comes out a couple of days before Christmas. It hasn't come out yet. We received a letter on the 22nd of December with some high-level sort of planning parameters and assumptions, but we're still waiting for the detailed plans. That's not stopped us from getting on with the detailed planning work this year. We've got a fair idea of what the financial position looks like. We've got a good idea of the performance targets that we want to achieve. We've got an agreed joint forward plan which sets the strategic priorities for the partnership, and we are getting on with the work, and we'll talk about that a little bit more in the private session of the board later on this afternoon. It's clear that finance is going to be a really important feature of the planning process for 24-25. I think Jonathan shared previously the baseline assumption is that we're estimating an 8% gap in terms of financial position in 24-25, and a huge part of the work is going to be how we work together as a system to manage and mitigate against that gap. It's also really clear that the local government financial position is extremely challenging. I think the local government finance settlement included a 6.5% increase in spending power for local authorities, but the significant challenges around that and significant pressures on local authorities and their ability to deliver a balanced financial position. This will impact into health and care services as well, and we're particularly cognizant of the risks around children and young people services, and we're currently developing a media statement on behalf of the partnership which describes some of those risks to the progress that we want to make around services for children and young people. We've got updates in there around innovation and the progress that's been made across the provider collaboratives. I'll not say anything more about that. The final thing I just want to mention is that we are continuing to progress the work around the ICB operating model led by Kate Sims. The consultation period and based on the structures and the job roles that we proposed ran from the 26th of September to the middle of November. After that, we refined and finalised the structures. We shared that with all the teams across the ICB in the middle of December. And we're now at the point in the process where we are confirming people into posts, and the vast majority of people in the ICB have been slotted into roles as part of this process. as well as carrying out interviews and selection processes for the minority of staff who haven't been slotted into roles as part of that process. Clearly a priority is supporting all staff through this change, including those who've been slotted in and those who are going through those processes. Also, what's hugely important is the organisational development work that we'll be doing alongside these changes, so that the changes that we're putting in place have got the best chance to be as strong and effective as possible. So that's all I wanted to say in terms of the update. I'll hand back to you, Cathy, thanks, and open it up to any comments or questions.
Great, thank you. I think we'd like to take questions in general about the report and then invite a discussion particularly on a continuing system risk in relation to health and care finances, particularly the links between NHS and local authorities. And we have local authority colleagues here today who I want to invite in a moment. But if we can take some questions and comments about other aspects of the report. Fatima, did you want to have your hand up?
Yeah, it was just a brief reflection of some of the work that the Equality, Diversity and Inclusion team are doing with Ian and colleagues in HR about the equality impact assessment, and to assure individuals that we're doing everything we can, one, to mitigate the inequalities we've identified, but also where we can to support some positive action and to reaffirm our commitment to a very inclusive leadership as part of the future of West Yorkshire.
Thank you, Fatima. Then we have AC, then Becky, then Jane. AC.
Thanks, Cathy. Thanks, Ian. Thanks, Jonathan, for the report. And I think it's also an acknowledgement in terms of how well the response to the winter work has worked through that sort of, I guess, letter from our NHS England colleagues. So thanks for doing the hard work in that particular space. One quick question, and I'm not sure if, Jonathan, you want to cover that later or now. As a result of the industrial action, the deficit that we are trying to manage in terms of the 9 million, do we have an estimate of how much that has affected our current position?
Jonathan, just if you introduce yourself and respond on that. I had a very similar question as well, the impact of another round of industrial action that wasn't planned for in the current budget forecast. Thanks, Jonathan.
Okay, thank you, AC. So I'm Jonathan Webb, Director of Finance and Deputy Chief Executive. Yes, so you're right to point that out. So when we did the exercise to reforecast our financial position and confirm how we would deliver against performance targets back in November, that was on the assumption that there would be no further industrial action. From a financial perspective, we've obviously have had more industrial action, as Ian's articulated. There are three financial impacts. One is the direct costs of backfill cover to cover for those lost days. The second is the impact on our elective recovery targets, because those non-working days will impact. And the third is lost opportunity. So the impact on other things we would have done had we not experienced those industrial action costs. So of those three, the one that's the most easily quantifiable is the direct costs incurred by provider trusts across West Yorkshire. That's circa 6 million for those days in December and January. We are currently working through what the implication was on our on elective work and therefore our elective recovery incentive payments. And we are doing some work to try and best quantify as we can what the opportunity costs are, but they're a bit more difficult to quantify. And we're working through with NHS England exactly how they should be disclosed in our month 9 reports as we speak.
Okay, and I assume that will then come to the next ICB Finance Committee, as well as have oversight across all 5 of our places in terms of financial planning. Okay, thank you, Jonathan. Becky, then Jane.
Thank you, Cathy. It may fit into this conversation you want to have about local authority and NHS, but 314, we've identified issues around children's mental health. We've talked about that many times here at the board, our concerns about the waiting lists for children and young peoples. We've talked about trying to create some parity between adults and children, trying to create some parity between physical and mental health. We still don't have that on our dashboard, but it is something that we talk about a lot here. And that being the case, I'm just checking what our strategy is for handling that now. So we had a really great conversation and a deep dive, Sarah, didn't we, at the board. It was really helpful to hear what the summit was going to be doing and what we were trying to do as a collaborative space. 315 looks like we're asking West Yorkshire ICS is urging the government for comprehensive funding for children's social care. It's unclear what the impact, the relationship is between that and children and young people's mental health of NHS services. I don't think we've spelt that out entirely clearly and what our role would be in that. So if we've got a strategy that we saw in place, this looks like something different and added in. I'm not for it, Kathy. I'm just not clear about what it means for our health service provision for children and young people's mental health and our concerns about that and our relationship with NHS England to secure more funding and more real attention around children and young people's services. We've all said that we want to put more money into that, but this balance between if we think we're lobbying for government for social care, are we not lobbying for government for children and young people's mental health services as well? Or why one, not the other? Or do we think one will make a massive difference to the other? It's not clear. So I think the 314 needs data in it. It doesn't say how much, how many more referrals. It doesn't say how. It's a little bit vague, and 315 is also a little bit vague. So I'm not clear what our strategy is. Thank you.
So, Becky, I think we'll take part of your question and invite Sarah Monroe to respond. I know there's been a neurodiversity summit, for example, recently, in the work of the Mental Health, Learning Disability and Autism provider collaborative for the whole of West Yorkshire, which links back to, for those of you who remember, we had a focus on topic from that collaborative in September this year on mental health services, both for adults and children and young people. But there's also a point in your question as well, Becky, about is this articulated fully as a risk in our own risk oversight here as well. So I don't know if, Sarah, if you'd want to respond. I don't know if, Brendan, if you wanted to come in as well. And then the other part of your question about the connectivity of children and young people's services between the NHS and local authorities, we just pause that bit and then I will come on to that in a moment. Sarah, could you respond?
Yeah, I'm actually just going to reference work that's been led across the ICB, not specific to the mental health providers, which Karen sent a latest update yesterday, which has got a lot of data in there on what the call for action is. So I don't know whether the whole of the board has seen that. Right, okay, because that's what I've referred to in terms of what is referenced around lobbying and trying to influence in terms of investment. Overall, yes.
And Sarah, if we were putting a new risk or reiterating a risk in our register, would you just sort of would you go back on behalf of your collaborative and just see what, maybe talk to Becky afterwards to see what we are articulating in our corporate risk register around those services? I think there's another point on what we're measuring and paying attention to, Becky, which is your other challenge to us as well. But if you perhaps could consider that, I'd really welcome
I'll follow it up with Laura.
Yeah, thank you. Okay. Brenda, did you want to come back in on that point, or did you have something separate?
It was to do with the industrial action. It was, I think we were talking about impacts on children's services and other services around the financial position. But the industrial action is broader and wider, to Ian's point, and this will be here for a period of time. I think much of the media attention has been about the BMA, but actually the Hospital Consultants and Specialists Association voted for strike action yesterday, or confirmed strike action yesterday. I think we've got junior doctors, consultants and other doctors with ballots that are still out and confirming further strike action, and we have the nursing unions, I think, who will equally be looking to what's happening with our medical colleagues. So there is the financial and operational context that is already challenged, but this will add another level to it across all of our sectors. And I think, to Becky's point, this will have an impact on services that I know there will be conversations further down the line about it, but it's a different variable to perhaps where we were in January of last year.
And it was something we thought was coming to a conclusion. So there's oversight, both provider collaboratives, places, as well as coming back here through Becky Quality Committee, Finance Performance Committee, as well as coming back to our March meeting. So this is something today as well as in the coming weeks. Okay, Becky, we still haven't answered all of your question, but if we just pause part of that there, and I wanted to bring Jane in with her question, comment.
Yeah, two things. Some of it's been picked up. First one was actually on the point of the industrial action. It was nice to hear that we'd had commendation from Richard Barker, the regional director, and I have to say, as a sort of non-exec member, it's pleasing. It feels as if it's been managed really professionally well, as a good team effort across the system. The communication that we got sounded on top of it, calm, but appropriately sort of in the detail of it, etc. So I just wanted to give my thanks to team here and beyond, I'm sure, who've been involved in that. And then I was going to just pick up on the Neurodiversity Summit, actually. I was just interested to hear sort of how and when we would hear about the next steps. I see that there's going to be a meeting again in February, but be keen to sort of hear what does get prioritised. And I'm not sure if you had members, hopefully from higher education, represented at the meeting, but for sure there's quite a lot going on in this space, and if we want to open it wider, and I'm happy to sort of try and get others to join. Thanks.
Sarah, would you respond on that?
Yeah, so as you would expect, it was a very broad-ranging engagement on the day and fantastic in terms of everyone that was there. And so the team have been distilling the key themes and actions, and there's a cross-working group, including people with lived experience, working through that to inform what we're going to come back to do. So the next workshop in February is very much around turning the outputs from day one into, so what does meaningful action look like and how would we track that through? So I think after that we could bring an update to the board.
Okay, and this is connecting back to focus on sessions we've had over the last 15 months or so in looking at particular services across all places and service providers as well, so we can follow that up. Becky?
Yeah, I think I went to Summit, it was really good. There was a massive amount of folk there, real energy, real passion, absolutely committed to this, both families, carers, people with lived experience, health professionals, social care professionals. It was really really good. One thing, Kathy, for us was that when I talked to people, they didn't know that we were talking about this at every single board meeting. So they didn't feel necessarily they had the support of the whole system around them. So that was one thing, I think, for us. There's masses to be done around pragmatic and obvious solutions and priorities, but certainly maybe something for Karen as well, just about how we engage with the folk that were there, about us as a board being really behind the work and the ideas that they had.
Thank you, Becky, and that was reiterated in our visit this morning to mental health and patient services, how you connect the operations to the policy and the strategy as well. But the team there this morning said that when they're sharing that kind of feedback with senior managers, it is very openly and well received, and then changes are happening. Majid, you wanted to come in, and then I wanted to get onto a local authority discussion.
Okay, a couple of things. So first thing, in terms of vaccinations, but I think it's just a general point. We talk about a reduction in uptake. It'd be good to get a feel of variation between different communities and what specific we're doing for future reports. So not now. The other thing was really good news under 3.2 around the 7.5 million coming to health tech innovation point, and there's an opportunity for local tech companies to get involved in some bids for funding. It's just to make sure that we do include the third sector in that space, to make sure that those opportunities are accessible to everybody. And the last thing was about local authority funding. Obviously, as more and more local authorities come under pressure, what conversations are we having as a system together to make sure what is cut over here doesn't get shunted as an issue somewhere else? So how are we working together to look at the overall impact of anything we change or cut?
Thank you, Majid. I wanted to invite Ian to come back in on the question around children and young people's services, which will then lead us into a discussion as one of our system risks in health and care in terms of finances. Ian.
Yeah, thanks, Kathy, and thanks, Becky. So I guess just to be clear, we're producing this statement on behalf of the partnership, the ICS, in response to quite a lot of suggestions from local government colleagues about the impact and the risks of this around children and young people's well-being across West Yorkshire, really. So it's a statement in direct response to the local government finance settlement that came out before Christmas. It's not directed to NHS England. I think Majid's hit the nail on the head in terms of the response. We're entering a planning process for 24-25, which we want to be joined up between the places of the ICB and local authority partners to really work through the risks, the implications and the consequences of this. We haven't got a full picture on those yet, but we'd expect that to be part of the conversations that are happening over the next 2 or 3 months between NHS partners in places and local authorities, really. So we're flagging the risk. We're trying to raise awareness to the issue. We will manage that through the planning process that we're about to go through.
Bev.
Thanks, Chair. So my name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB, and it's just in response to Ian's comments, and it's to offer some insight into some of the conversations that have already been had that will continue, but also around mitigation of risk. So there's been work in the system with the directors of children's services in all places in order to look at the approach, interrogating some services where placements might have broken down, where there are significant risks with either individuals or with services, and there is a plan in place to mitigate those. It's work in progress, but it will continue, and we're also going to be reviewing the risks at the children's board as well as at system level. So it would just to offer some assurance that this work we are looking at as a system. Thanks.
Great. And I leave you, Becky, as our Quality Committee Chair, to discuss with Bev and others what you might want to bring for oversight at quality level. So if we just then move on to one of the risks we've talked about for a good 12 months now is the connectivity of finances in a health and care system, particularly between local authorities and the NHS, and then how that also affects the voluntary community and social enterprise sector as well. I think we were in this room last year when we had a briefing on that in a private session, making sure that we all had baseline understanding of that. I know there are discussions going on at place level, and if place leads would like to share anything, please do. But I know we have people working in local authorities around the table today. So Tom, I don't know if you would just share some reflections with us. It's prompted by the statement we're making around children and young people's services, but there is a broader issue for all health and care. And then maybe Robin, I don't know if Rachel, if you want to come in as well. Tom.
Thank you, Chair. Yeah, Tom Redden, Chief Executive Leeds City Council. The situation in local government is severe in terms of the finances, and although, as Ian said, the overall spending settlement was a 6.5% increase in what's called core spending power, which is the overall ability to spend on services. That is well below the amount that the LGA, which is a pretty objective, although a local government sector representative body, position with which it had got to in terms of a couple of £1 billion gap for the country as a whole. The difference on the ground is that we have a sort of almost a sliding scale of how severe the challenge is this year for each of the authorities. And I think you'll be aware that Bradford are in the most significant position in terms of challenge, and are in dialogue with the government at the moment about whether they will be able to set a balanced legal budget based on the settlement that's happened, and that is playing through at the moment. But they've identified some savings already that could go some way towards meeting the financial challenge that they've got. Next in line, I think, is probably Kirklees, although Kirklees have been delivering a plan of reductions over a slightly longer period, and so I think are better is a sort of relative term in these circumstances, but where success is not having what's called a section 114 is that you actually can't set a legal budget. Kirklees are in a bit of a better position, and I think are more confident of being able to avoid that, but they are making quite a lot of reductions. Then comes ourselves, Leeds, who we've got significant challenges and have announced just finished a consultation on a very significant amount of savings for us, about £60 million, including, and that's slightly lower because we've got a programme of asset sales that we are using to smooth the challenge in front of us. And then I think Robin could speak for Calderdale, but I think it's Wakefield and Calderdale probably come next. So there is a differential across the region. The position that the ICB have come to in principle about helping make the case for additional resources on children's services is really, really welcome for us all, and I think is something that is quite important in its own right. I think in symbolic terms for the people working in the services, as well as for the national organisations to receive something in those terms. And it's been done in the right way, and it's done in the right tone, and I think it's a very sensible and pragmatic response to the issues on the ground. Because the reality is, coming back to Majid's point, that there will be an impact on every part of West Yorkshire of the local authority budgets that are being set at the moment. And some of that impact will be felt immediately on organisations who will be having their grants reduced, or they'll be having a service withdrawn or reduced in an area where they know there's going to be an immediate impact. And in other parts, it will be what you might call a slower burn effect, where we'll be reducing what we can do, which will inevitably lead to more demand and pressures in the system, not necessarily this year, but in future years. So what we're all trying to do is to work with our partners, particularly in the non-statutory sector, as well as NHS partners, to manage that position, that really challenging position, to avoid the impact on the most vulnerable people in West Yorkshire. I think that's something I can say for every council across the board. And that is really difficult, and it's getting more and more difficult. So I think what I would say is I would propose that we do go ahead with the intervention as it's proposed. I think, just picking up Becky's point, there's no doubt whatsoever that the pressures on children and mental health services have massively been impacted by the pandemic, and our Director of Public Health, Victoria Eaton, just did an annual report that showed that a third increase in the challenges, and that Sarah and the other mental health trusts are having to really cope with more and more extreme cases and not be able to do the other things that we know heads off, you know, that need. So a separate look at that and, you know, come back to that, I would propose is a sensible thing to do. But I don't think we necessarily need to worry too much about not lobbying for the NHS bit by lobbying for the local authority bit, because I think that's the bit that the message needs to happen more quickly.
Tom, thank you very much. If we come over to Robin, then want to invite Rachel and Kim on behalf of the voluntary sector. I don't know if Mel, if you want to just any reflections for you from Bradford District and Craven Place as well, just that Bradford's been referenced there. But Robin, to you, and I think as colleagues in local authorities, if you can explain why. I think if you think about, usually we're getting a couple of hundred people watching these meetings, either now or on record. Why are we in this situation without getting political? Would be some reflections
Yes.
there would be really helpful.
We're also returning officers.
Yeah, and the returning officers. And also
will not be doing
my challenge to you all around the table with some of the most senior people here in this system, so thoughts on sharing what you're already doing or what you can do next would be really welcome. So Robin, to you.
Yeah, so agree with everything Tom said. I think that this letter, this communication is a lovely example of what Harris said at the beginning, which was the West Yorkshire way. It's the West Yorkshire way to think about children and people living healthy lives in our communities. And it's been done, I think, by the system, the ICS, as the kind of system response and the partnership. But I do think that if we think about the ICB's core role and the element around social and environmental outcomes for our place, we know that people's ability to live healthy lives is about the social context of their lives. And Michael Marmot yesterday issued a very stark set of figures again about the last 10 years, and following the Health Foundation last week indicating, again, not in a political context, but in a factual context, that the parts of the country that have had, even with all local government having this level of reduction in financial support, that places like Bradford in particular, and the North and Mets and the poorest parts of the country, West Midlands, have had a disproportionate impact, and the data is there. So it's been really difficult, and everything's connected. Everything is connected. So I see the three big, huge issues now for local government and actually people's healthy lives are children's social care, adult social care, and homelessness. And those services which contribute to people's lives. And the biggest single reason for a child being referred into the front door of our children's social care is domestic abuse within the family. You know, and the context around mental health and housing and all of that. So it's all connected. And I think what we need to demonstrate is the cumulative impact of this. And I think Tom's profile of our 5 places is right, although I'd say different places have done different things already. And one of the problems of seeing this as a Section 114 notice or not is actually most councils are thinking about decisions which are made historically by councils close to a 114. to not be in that position. So there's almost this thing around, there's 25, 30 councils in dialogue with government, depending on which paper you read, but all councils are having to think about this. Very few are not in that position, and disproportionately in our part of the world. So I say we'd welcome it. It's all connected, and we know that children's health and well-being, through colleagues joint commissioning at our children's front door, with mental health, with NHS, with local authority, with police and the voluntary sector working together, is the way to mitigate and minimise the impact of this. And thinking now about what are the cumulative impacts. So in Calderdale, when I came to Calderdale, 49 pence in the pound of council tax was spent on children and adult social care. 49. It'll be 70 this year. And in Bradford, it's 87. We provide around 600 different services in local government, depending on how you cut it, to everyone that lives in that place. All of us use some element of local government service every day without noticing a lot of it. And some things we do notice, like our bins, etc. But actually, we provide all of that service. And of course, now that 30% in our case, or 13% in Bradford's case, is all the things that people think about is what a council is for. On the roads we've driven to today, or on the streets we've walked, or in the parks we've walked through, or in the environment that we live in the public realm, and how safe we feel and how we live our lives and how we feel about our communities and the public realm of our place, and how that affects people's health and well-being, actually. So it's all connected, and we know that the impacts of that are severe. And just to so homelessness, our level of homelessness families in Calderdale, historically not been one of our biggest issues compared to other places, has doubled since the pandemic. Number of children on education, health and care plans quadrupled. The trajectory of children in special educational needs, special support, additional support, is just going through the roof in the future years. Both those in school, those leaving school, entering often into adult care with multiple and complex needs. So, and I think the leader of Bradford says poverty is expensive. So, yeah, I'll leave it there.
Thank you, Robin. And just for anyone watching the meeting and taking an interest in this discussion, there is something in the report around the fact that the Local Government Association, the LGA, as Tom referenced earlier, says there is a £4 billion funding gap in England for local authorities over the next 2 years. And as you were talking about, that's particularly affecting social care, children's care and temporary accommodation, as you were talking about, and homelessness. Just want to reference that. So, Rachel, would you introduce yourself and just give your viewpoint, and then we'll come to Mel, and then I'll come back to Jonathan and Ian on any reflections, unless... Oh, Kim, you wanted to come in as well. So, Rachel.
Thank you, Cathy. So I'm Rachel Spencer-Henschel. I'm here as the sector representative of the West Yorkshire Directors of Public Health. I'm also the Director of Corporate Resources for Kirklees Council. What I'm not going to do is duplicate what Robin and Thomas said, because they've absolutely nailed it in terms of where we are and some of the challenges. But with my public health hat on, I suppose one of the things that might help the board is, obviously in 2013, public health was moved into local government. And with that became a set of responsibilities that we have to deliver. And I think sometimes it's easy to think that because public health grant is essentially ring-fenced, that kind of means we can carry on doing what we were doing. And some of those things are services that quite a lot of the population don't know are local government funded, like sexual health, substance misuse, health visiting, school nursing. All of those are commissioned directly from local authorities, or provided in some cases. But I actually think that where the risk comes is less about the grant being touched, because in most cases, and particularly in West Yorkshire, we have a lot of passionate leaders and chief executives who support public health agendas, and that's very unlikely to be something that they go to. But actually the benefit of being in local government is how we influence the broader system within local government, and how we work alongside services that will help to better deliver outcomes. And obviously as services in local government reduce, and the difficulty is how that doesn't become the preventative services, because the value in terms of statutory responsibility or giving a clear return on investment is less, means that you've got less to influence from a public health perspective. And we know that that means that the public health demand in terms of some of those secondary prevention services, the demand on the NHS and obviously the demand on things like children and adult social care will only go up. So our biggest challenge is how we retain the focus on prevention and work alongside voluntary sector colleagues. And I think my biggest challenge with looking at our budget proposals, that yes, we've got some and they're comprehensive, which is great, but it's how you make sure that one decision here and one decision there doesn't have such an impact on some of our VCSE providers and others that it causes a massive impact. So the real trick is looking at that cumulatively, and I know that the 5 directors of public health across West Yorkshire have contributed to your statement to make sure that we don't lose sight of the public health elements of funding, for example health visiting and school nursing, which will be put upon so much more as other services reduce going forward.
Thank you very much, Rachel, and that reiterates and complements what Majid was asking earlier. And I know you've had the experience in Kirklees where you've worked together, and I know the Place Committee, you've in some ways learnt as you've gone in having those discussions on not making decisions in isolation and making them in partnership to understand the consequences, good and bad, of those decisions. So come to Mel in Bradford, then to Kim on behalf of the voluntary sector, and then I just want to invite Jonathan and Ian to sort of summarise and respond, and then we'll move on to the next item. Mel.
Thanks, Chair. So we have a new Chief Executive in Bradford of the local authority, Lorraine O'Donnell, who was able to come to our her first health and care partnership meeting last week, and made an apology for being largely absent from a lot of other discussions since she arrived in Bradford, because she's been completely consumed with trying to navigate and negotiate how we are going to avoid a Section 114 in Bradford and come up with alternatives. So she apologised and said, well, it's not for the want of supporting the partnership, but I've just been very, very busy and consumed, so please forgive me. And we did, because we appreciated the gravity of the situation and the way that Lorraine had to apportion her time. But having heard much of what Tom's alluded to directly from Lorraine, we agreed to increase our risk on this particular issue at Place to 25, which is unusual. We don't usually have risks of that magnitude. It may hopefully come down if we get some signal that the application made for emergency funding has been successful. But for now, it remains incredibly precarious, and indeed, as Tom said, an interim budget has been put forward to the council pending the outcome of that, and that in itself is a very unusual step. And that interim budget has proposed a reduction in funding in some non-statutory functions, principally at Place, so things like parks, leisure, closure of some waste centres. Those things that are judged to be more discretionary, including, sadly, and I'm sure Kim may come on to allude to this, a reduction in the contribution made to the voluntary sector to support their infrastructure. However, on hearing all this as a partnership, what we did was try and turn this into a more positive catalyst for the partnership to galvanise, to support one another, but to galvanise around the problems and push ourselves into a space that I think we have been around the margins of in some instances. So a really good example that was given was that we had a paper, and it alludes to it in our AAA report, about what do we do with our approach to listening into an engagement as a health and care partnership going forward. And there were some proposals put, but then we'd also heard from Lorraine about the financial position at local authority. And what we were proposing was to establish a process and a system and a bit of an infrastructure to do engagement as a health and care partnership. But what Lorraine sort of challenged us was, well, we as a local authority have to do engagement and partnership. So how are we going to do this together? And what was sort of put back was, I think it's an interesting shift in language, was, oh, well, we do work very well with, we will interface with, we'll join with. And I sort of said, are we not in the territory now of being much bolder than that? What we should be saying is, we'll just do it once. We'll do it once, and we'll do certain things, this and others, for each other. and we'll trust each other to do those things that we've agreed to do for each other and avoid duplication and unnecessary waste. So trying to turn this into a bit more of a positive, it certainly is a catalyst for a different sort of discussion, and I think we should just hold on to that.
Thank you. Kim, would you introduce yourself?
Yeah, thank you. Kim Shuttler, I'm the VCSE lead. Colleagues have really well rehearsed the impact on the VCSE, and I do want to talk about the VCSE, but I suppose I want to talk about our collective strategy around the risk to early help and prevention, as Rachel has mentioned and Tom has mentioned before, and of course to widening health inequalities, because it feels like we talk about it around this table, and I wonder where there is a sort of a detailed piece of work that takes a look at the aggregated impact of the decisions that are made. Absolutely, I'm involved with the Bradford conversations about an 83% cut to the VCSE infrastructure from the local authority proposed. Infrastructure is something which is hard for most people to understand, but if I can share, 95% of the VCSE nationally and in West Yorkshire are small or micro. So if you imagine the thousands and thousands of people that are supported by those organisations in our communities, what you buy with your infrastructure is you buy a collective strategic leadership, you buy a back office function around support around crucial things such as governance, safeguarding, and crucially bringing money in to West Yorkshire from outside of the area. That is difficult to quantify for all of us. We know that our gift is our rich diversity. It's also the bane of our lives, that it's very, very hard for us to put numbers against. However, I think as a partnership, we have sat around this table for a number of years and recognised that health and care transformation cannot exist unless we move towards early help and prevention, mobilising our communities, utilising our community assets, and really investing in the VCSE as equal partners. So really this is a test of our mettle. Whilst we've got to be very, very pragmatic about it, and I think, it's really good hearing Mel say about those conversations. I think as a sector, we have to come to the table with colleagues and be given a seat at the table locally to have those partnership discussions about the mitigation of risk. That's really difficult to do in a traditional context of procurement. However, we can help to mitigate those risks if we get into those dialogues about how that's done. So I suppose that's my encouragement, is that I think as an ICB we need to be looking at this more strategically and collectively, rather than just at a place level and the impact on those things. And at a place level, my plea is that we do more of what Mel said about moving it into risk mitigation and what we can do together to do the best for our communities.
Thank you very much. And also I'd say, Kim, also what lobbying and influencing do we need to do? We've talked about what we're doing with local government, and I think maybe it's a conversation we can have outside of the meeting and afterwards. What lobbying do we need to do in other directions with other sectors and bodies as well as talking to government at the same time? Okay, and there's a reiteration there on risk management, collective decision making, not sitting in silos. Robin?
Yeah, just to say from our place perspective, we are doing what Kim said. We're doing a whole session of the Partnership Board, which will be a public meeting also with the voluntary community sector later this month about the impact and harm, actually. And there's two elements. That one is the direct service impact for the sector, but actually the community place impact, because we know the sector in our place, and we're not unique in this, is often picking up people at the margins and at the edges of literally those arriving into our place, but also those who maybe other doors have become harder to get through. So we are doing that. I think, and I said we did have a joke about not being political, and I'm not going to be political, but I think I would say that our political representatives are saying they are proposing things that they recognise will have impact that's harmful, or that they recognise there is a sense of a conflict with some of the purpose they came into public life for. And I think just need to recognise that, really. So I don't think that the decision makers who are operating in a legal and statutory context around the kind of consequences that Mel's described, and that is true for all councils, are not mindful of that that duty, but also that real challenge that they're in. Thanks.
Thank you. I know we've got Hannah AC, and then I still want to come back to Ian and Jonathan. We are now running behind, but this is an important discussion. Fatima as well, and then we must get to the Board Assurance Framework with Laura. One thing I'm just thinking through, and we have our colleagues from Communications and Marketing in the room, is that we're putting together a briefing. It's finalised this week on Children and Young People Services, but I think there's something more broader. We've had a number of statistics today on broadly the amount of money, pence in the pound, the effect on the voluntary sector in general. So I think there's just something to look at more broadly on what we could do to make sure we've got a briefing for everyone around this table, as well as other colleagues in the partnership. Can I ask people to be brief, please, in their next comments? Hannah, then AC.
Thanks. Just picking up on Kim and Robin's point, that need to understand the impact, and Ian talked about the consequences as a system, but it is about the consequences to people, isn't it? And particularly groups of people who are already experience inequality. So what will this mean to disabled people? What will this mean to people with learning disabilities? What will this mean to unpaid carers? And I think it's really important as a board that we have that understanding and that ongoing understanding and around that. And I suppose part of the transformation that we've talked about is we're going to have to do things differently, a bit like Kim's talking about this. We've got to do things different. We can't make decisions in the
to the NHS West Yorkshire meeting here in Wakefield today. We've just been having a discussion around risks in the system, particularly finances and health and care. We took a short break there because we had a technical fault, and we're back up and running now. What I want to do is ask colleagues just to summarise our discussion. So over to Ian and to Jonathan, and then colleagues, we'll pick this up again in our private discussion later today. Ian.
Yeah, thanks, and thanks everyone. I thought it was a really rich and helpful discussion. Thanks particularly to Tom and Robin and Rachel for articulating the local authority position really, really clearly. I think I'm hearing support for the statement in terms of what we're trying to do with the statement around children and families, and thanks so much to Karen and the team for putting that together. I know it's an awful lot of work to coordinate that across the partnership the way that she has. Hopefully it goes without saying that the NHS financial position is also really challenging. That was something that we put in the board report, and I think that will feature in the discussion we're having later around 24-25 planning. And I guess the big message is that we need to use this planning process to get these conversations in the right place and have, come up with the right set of priorities and the right mitigations around this. And I think that the work that Jonathan's going to describe around that's going to be really important. It absolutely needs to be done across NHS and local authority partners in true partnership, I guess, and with VCSE partners. So thanks everyone. I thought it was a really good discussion.
Thank you. Jonathan?
Yeah, just I guess just to sort of just slightly add to that, I mean, I think it is really helpful to understand the local authority perspective. And I suppose the tipping point of that sector in terms of the potential prevalence of Section 114 notices is unprecedented, to be perfectly honest. These used to be very, very exceptional cases driven by very, very exceptional circumstances, and I think the prevalence is changing. I think there is something as well around just reflecting, as Ian said, on the NHS financial position, which will be very, very challenged next year, as it's been very, very challenged this year. And we're not going to be able to do that through traditional efficiency, traditional productivity. It will require fairly significant scale transformation, and it will require fairly large scale prioritisation, which may include disinvestment in some areas as well. And I think that's the territory that we'll need to get into as a board, to think about what we can afford and what we can't afford, while making sure we spend every pound of money we can in the best way possible.
Thank you very much to you both. That's really helpful. I know that we have an ICB Finance Investment Committee in early February, where we'll be looking at place plans. So this is a live discussion at the moment. So thank you very much for the discussion today. As Ian and Jonathan have said, I think there were some principles there about making sure collaborative, collective decision making, understanding the consequences in a health and care system, aiming to do things once, it's spending that public pound in the most effective way, making sure that we have the investment in both in infrastructure and service delivery in the voluntary community and social enterprise sector, true engagement with local people and listening to them on their needs, all supporting the Children and Young People statement, and also making sure in our respective roles whether what is our influencing role or what is our lobbying role in these situations at the moment. But we'll hear more at the next board meeting, and I know we've got oversight as an ICB through the Finance Committee in a matter of weeks. So thank you. What we're going to do now is move from item 6 to item 8 on winter planning. This was a focus on for us today. Thank you to a number of people around the table, including Anthony Keeley, who's prepared the report. And Nick, I know you've joined us today. Would you just introduce yourself, particularly for people around the table as well as people watching the meeting?
It's not working. Good afternoon. My name's Nick Smith. I'm the Chief Operating Officer for the Yorkshire Ambulance Service.
Nick, thanks for joining us today. So, Anthony, over to you. Would you introduce yourself? And again, thank you for preparing this report.
Thanks, Chair. I'm Anthony Keeley, the Director of Planning and Performance for the ICB. We brought an update on our preparations for winter to the last two meetings of this board. And those were updates, if you like, on all of the work that was leading us to this point, how the health and care system would be able to manage the seasonal pressures which we experience every winter. So we've scheduled a slightly longer discussion today and invited Nick Smith from Yorkshire Ambulance Service and Lou Auger, the Deputy Director of Planning and Performance from the ICB, to join us. Really just to, if you like, reflect on how all the work that's been going on across West Yorkshire to prepare for winter has paid off, or otherwise, I suppose, in terms of how we're managing the current situation. Ian mentioned earlier that as well as the seasonal pressures, we've also, of course, had to manage the impact of industrial action right in the thick of late December and early January levels of high demand and pressure. So we've had those two concurrent issues to juggle. So the paper you have is just a broad update on progress with the work we've done. I don't intend to spend too much time on that, but just to give you some of the brief headlines from the paper. It sets out the progress we've made across 4 broad areas. The first one was around implementing the high-impact interventions that were set out by NHS England in relation to the urgent and emergency care priorities for the NHS as a whole. So the paper just indicates that we've continued to make progress with those high-impact interventions across places. That's ongoing work. There's more to do. It'll carry on through the rest of the winter and into next year, and we'll carry on prioritising those developments. But we are seeing good progress across the system on that. The second area of progress that the paper talks about is in relation to making sure we've had the right capacity in place to respond to levels of demand. And Ian talked about the reviews of our operational plans that we undertook in the autumn that helped us assess whether we've got the right capacity in place. At this point, we actually have something like 150 beds open beyond what we'd actually planned to earlier in the year. So I think that's been a significant effort by our acute trusts in particular to make sure all of those beds have been available to anticipate levels of admissions and demand that we've been preparing for the winter. So I think West Yorkshire's in a pretty good place generally in terms of the capacity that's available both in the acute sector and elsewhere. And that's helped us with the strike action, I think, as well as the levels of respiratory infection that we've had to manage. The third area of progress the report talks about is the work we've done together to make sure we've got the right partnership working, the right system coordination in place. And it talks about the further development of arrangements like the System Coordination Centre and the implementation of the new framework for assessing operational pressures and escalation levels, what we call the OPAL framework. But we should particularly, I think, highlight that all of the really strong partnership work that's taken place across the West Yorkshire Association of Acute Trusts, the other provider collaboratives and each place partnership to manage pressures. And the fourth area that the report touches on is the support we've had available for our staff and the workforce across health and care in a number of areas to cope with winter pressures and levels of demand. So that, in a sense, sets the scene for the work we've done. We thought it might be useful to hear from colleagues from each of the 5 places and from Nick's perspective from Yorkshire Ambulance Service, just to understand what it feels like at the moment. I suppose how the system is doing, and in particular from that to pick up whether there are any areas that we still need to resolve collectively in terms of mutual support or system working, and then I suppose also what we can take out of all the work that's gone on, all of the arrangements that are in place in terms of learning for future. Well, first of all, next winter, but before that, other periods of high demand, which we would typically expect, for example, around Easter. So it would be really helpful just to hear those reflections from colleagues and then what we can take forward from those experiences.
I want to talk about an improvement in the position compared with last year, but I think before I go into that, firstly to echo what Mel has said in terms of thanks. The amount of hard work from clinical staff, other professional groups, social workers, social care staff, to keep the system going and keep it moving is phenomenal. And I think it's sometimes we stand at a high level and overview and we forget the day-to-day decision-making, responsibility and so on of colleagues that work right through our system. And not just them, but some of the managers and administrative staff that support them, because without them, I think things would be much, much tougher. I think the second thing, before I get into some of the improvement we've seen this last 12 months, is we don't want to normalise not great. Last year was really, really difficult and felt horrible at times. We're not in that position this year, but that doesn't mean it's fantastic. There are still people waiting on corridors, still people waiting more than 4 hours. I won't touch too much on the mental health services, but we still have a lot of people out of area. And those things are not good things, and we know we need to do more. So we mustn't normalise the current standard. We need to continue to improve. Having said all that, the position, particularly around acute services this year, is significantly better. That's for 2 reasons. One, in Leeds, we've been having a major programme of change around something called Home First, which is a real review of the whole of our intermediate tier discharge and flow arrangements. And that is now really starting to benefit. It enabled us to do what we couldn't do a year or so ago, which was close 2 of the hospital wards in advance of winter, because we had managed the flow through the system much better. That has then given us capacity to open when the pressure came on. And we have opened it in line with our plans. So the second piece was the planning around that. We planned to have 2 wards available in the hospital, some additional capacity, if you like, around the edge of the hospital, outside in community. And we've opened those in line with the plan and not to the extent we thought we needed to. And what's been really good is we're able to open that and close it as we require. So it's genuine flex in the system that we've not had previously. We also plan to be above a 96% occupancy through the particularly difficult period of January, February. We are above that, but we're not consistently back at the 99, 100% in the acute hospital that we were at this time last year. We're more at sort of 97, 98%, and again, that was in line with our expected trajectory. The kind of work we've done around Home First has included things like really improving the length of stay in rehabilitation and other external discharge facilities. So the average length of stay in some of our rehabilitation units was sort of 42 days. We've reduced that to 37 days. That doesn't sound huge for each individual case, but when you multiply it up, it's a huge improvement in terms of the flow and ability to move people through. We have a whole set of schemes also at the front door that we've been working particularly around sort of paediatric asthma, for example, that have then also relieved some of the pressure on the acute sector. Having said that, still real challenges. We do occasionally go to Open for some of our GP practices because they do report that regularly. And we have seen those pressures from time to time, but some of the help that we're able to provide through PCNs has been good in that respect. And just to come back to, I don't want to underplay it at all because it is significant. In many ways, if we take the out-of-area placements around mental health into account, we're probably the Mental Health Trust is operating 130% capacity. That is a significant, I don't think it's a particular peculiar winter challenge, but it is a challenge for our system that we will continue to need to get to grips with. I think I will probably stop there. The good bit that we are quite happy about is we were always on the very bottom of the naughty list for no reasons to reside, percentage figures. We're now firmly in the middle of the pack, and that's sustained. And that is really important because it allows us as a system to talk about the things we need to talk about rather than one particular indicator of performance.
Thank you, Tim. That's really, really helpful. And one of our next board level visits is to Home First in Leeds, which you're helping to host. So thank you for that. I look forward to that visit. So we're now going over to Kirklees and then we'll go to Calderdale.
Thank you. Thank you. I was actually at the end going to touch on the mental health point that Tim has raised, and I'm sure Sarah will want to say something about that. So rather than repeat it, well, I have just repeated it, haven't I? But rather than do it at the end, I'll do it now so I don't forget. So generally in Kirklees, I think, again, there is a risk of us starting to repeat the same sort of messages, isn't there? And I also wouldn't want this to go by without acknowledging the amount of work that goes on across partners, both in terms of planning and delivering services. Because coming into this winter, and particularly that period in December in the lead up to Christmas, colleagues have been planning for what is traditionally the busiest time of the year, but knowing that there was also this period of industrial action, and the work that colleagues have done coming together to get ready for that has been incredible. I think it's fair to say that a lot of what we've heard already from colleagues and from Anthony about the overall West Yorkshire system is reflected in Kirklees. The Kirklees system's broadly been at Opal 2, Opal 3 since Christmas, again with spikes to Opal 4 in particular services or particular providers, but not for the sort of sustained periods that we would have seen last winter. I think Tim's point is really important, actually, about what we normalise. And I remember, see Brendan in my eye line, but I remember you saying that this time last year. We must be really careful that this does not become our normal and everything else feels much better. So I think it's quite a timely reminder on that. A couple of things maybe just like to pull out particular, which maybe we haven't touched on yet. I'd like to say a little bit about primary care and in particular the work that's gone on in general practice. I'm pleased and really I would like to give it a bit of a special mention that the appointment position, that the number of appointments that GPs within Kirklees are continuing to offer. We're doing well in terms of our contribution to the national aspiration about increasing GP appointments. But again, every time I look at this information every month, they are delivering more appointments than they were this time last year. And in terms of the sort of baseline capacity, that increase is huge. But in addition to that, we've also seen a benefit from having the additional extended access and bank holiday cover that's been available to our system over bank holidays, periods and Sundays as well. The other additional thing that I know we all have, but is our ARI hubs, which I know colleagues have said have had an impact this year. And again, it's been welcome being able to put them in place over a period of a few months over the winter period. So again, another positive. I think maybe what I might just mention in terms of areas to flag and areas of learning, the industrial action impact, I know we've been touching on it as we've gone through this meeting already today, but we did acknowledge that there were certain points in the last period of industrial action where the numbers of junior doctors taking action was at the highest point it ever had been, and this is after several periods of industrial action. So I think we need to recognise there is still that level of action being taken and the impact that has. But equally, being able to see different things happening because you have the consultants at the front end of the system and what that does to patterns of admission and decision making, but also what I've been told it does to things like length of stay. So actually those people who are being admitted to hospital are more complex, which might mean they do have a longer length of stay, and therefore the complexity of their discharge is different to maybe what it would be in normal times, if there is such a thing as normal times. And the third point I was just going to make was around the mental health pressures, which I've done. So I'll leave it there if that's okay. Thank you.
See people nodding around the table as you're sharing some of those reflections as well on learning, so thank you. Robin, to you in Calderdown, then we'll go over to Mel.
Yep, thanks, Kathy. I'll build on everything that's been said, and particularly we worked really closely with Kirklees for the shared footprint around the acute trust. So, Urgent Emergency Care Board, jointly led by 2 GPs from each place, I think it really shows the power of collaborative advantage. Collaboration actually is a good self-interest. It actually means you kind of work better together, and I just commend Anthony and the senior team for getting us together quite early. We didn't have that thing where suddenly you remember it's winter in November. We started this early, which is good. Also commend colleagues in CHFT for the real can-do approach and the real activity around the front door. Only one day, I think, with surge capacity reached a limit. Just finding other things to add. We made available some additional acute respiratory hubs, 2 additional ones early December. The out-of-hours care was well used. Care homes remained stable. That's been really important, I think. We haven't said much about social care, but actually the stable position of provision. Community pharmacy has worked really well. And just a call out for Health Watch and the voluntary sector around targeted communications around Together We Can, focusing on things like mental health, the role of community pharmacies, and really thinking through the impact of sophisticated communications, and thanks to Karen and the core team for that. So just really build on that. It's been positive, but I think Tim's right. Let's not be complacent. Thanks.
Thank you. That's really helpful. I'm going to ask Anthony towards the end to ask why it worked this year. And one of your points there, start early, which is one thing that Anthony said to me yesterday. But we'll pick on some other points in a minute. So Mel, over to you in Bradford District and Craven, and then we'll come to you, Nick.
Thank you. So the benefit of going last is a lot of has already been said. But what I would say, though, is with every strike that passes, we get better at dealing with it and handling it. So it does feel more controlled. But I would say that the impacts are felt more severely every time we have a strike. So whether that's the human cost, people waiting for procedures, cancellations, the emotional stresses and strains that we place on colleagues by asking them to do extra, we're really kind of tapping into that reservoir of goodwill that is diminishing very quickly, and the financial costs of that as well that we've yet to quantify. We've talked a lot about the impact on acute. I just wanted to flag up there are also impacts in other services, less evident perhaps. So colleagues at Bradford District Care Trust who provide community dental services, some of those lists had to be cancelled. These are patients who are oftentimes with neurodisabilities and quite chronic problems who require a general anaesthetic, and it's that element that has caused that cancellation. We talk about the impacts I've mentioned, but in terms of quality and patient safety, because we've got senior decision makers and they are orientating themselves largely disproportionately at non-elective urgent work, the quality of care and the patient flow is very good. So we are not seeing patient safety issues and incidents, which is good, but it's the hidden impact of those patients who we don't see that we worry about. Ambulance delays, diverts, etc. In general, handover times are improving. There was no noticeable deterioration in these in either trust during the industrial action period. In terms of our capacity, we've flexibly used between 0 and 24 beds in each of our acute trusts, but we've also taken the opportunity to reconfigure some of our wards to better cope with the types of demands that we've had. So in Bradford Teaching Hospitals, we've now a dedicated step-down rehab stroke facility and also a younger frailty unit, which is an acknowledgement actually of the kinds of patients that we treat in Bradford often have multiple comorbidities and exhibit the signs of frailty at much younger ages than you might expect in the more general population. So those patients under the age of 65 can now have a much more multidisciplinary team approach to their care, and that's serving us very well. Both trusts have seen an increase both in longer lengths of stay for patients and those with no criteria to reside, and we continue to work with local authority and independent sector providers on a redesign a complete redesign of our intermediate care offer across Bradford District and Craven. It is a challenging area as we've seen significant reduction in the numbers of local authority provided intermediate care beds. So as Tim's alluded to the success of Home First, we're looking at our neighbours in Leeds to ascertain what we can learn from them to make up for the change in makeup of our intermediate care bedded facilities. As a consequence, not just of financial pressures felt by the local authority in consolidating their offer, but also some workforce shortages in that particular sector. Urgent care, Bradford Teaching Hospital continues to benchmark really positively against acute trusts, both regionally and nationally, but at Airedale Hospital there are significant challenges in the achievement of the planned performance against the 4-hour standard, which is to be 76% by March. Number of contributory factors there. The additional winter escalation capacity has been reduced due to the Decant programme to address the RAC issues at Airedale, along with awaiting some capital approvals that have now been mobilised to create an urgent treatment centre that should be open by June. They have been able to strengthen the workforce. They've appointed 8 senior clinical decision makers and additional nursing staff. And colleagues have mentioned the virtual ward offer. We're quite fortunate in Bradford District and Craven in a combined offer of about 135 beds currently for the people in our population, with an aspiration to achieve 155 by the end of March. Just a few words about primary care. It is busy, but it's managing, and we've put additional support in for winter. We've had paediatric hubs in place till March, which provide support between the hours of 4 and 8 p.m, which are usually the peak demands for paediatric patients who otherwise would attend at ED, and we've seen a significant reduction in those numbers, in the order of 6% since those hubs have been open. So as a really helpful alternative. And so we're going to build on that and work with Yorkshire Ambulance Service to create a straight to the hub pathway, so to avoid any contact with A&E for those appropriate patients. We talked about vaccinations. Ours was the lowest in West Yorkshire at 44 for COVID, 42.4% for flu. Despite numerous campaigns, the appetite just does not seem to be there as it has been in previous waves. And just a note about, notwithstanding all of this, we're still working on some developments on the interface between primary and secondary care. So we have expansions of community dermatology, primary care glaucoma monitoring services just been established and are working really well, and expanded primary care neurology and headache services implemented as well.
Thank you, Mel. I want to hand over to Nick now at Yorkshire Ambulance Service. Hannah, I can come to you after that if you want to just share something on the Health Watch Insight report, which we've got to complement this report today. Then I can take some brief questions, and then colleagues will take a break. So let me just check around for questions already queuing up. So we've got Fatima, Becky, Tom, James, Majid. Thank you. We'll keep the list. So Nick, over to you. Do you want to? I'm going to turn my mic off. Hopefully by pressing your mic, it'll turn on.
Yeah, that's great. Thank you. So from a Yorkshire Ambulance Service perspective, it's been a better year than last year. That's despite a 17% increase in demand, which is quite significant. And I think what's really interesting is the variance between the different places within West Yorkshire. We saw a 20% increase in Wakefield, 20% increase in Bradford, but only a 4% increase in Wakefield. So there's definitely something to look at and explore within there as well, going forward. So like the rest of the organisations, we had our plans in place, winter plans. We realised probably mid-November into December that it wasn't going to be enough, so we introduced what we call a December initiative, which meant we went further with some of our plans that we had in place. And that first 2 weeks in December were really, really challenging with performance. We then found the second 2 weeks were better over the Christmas period. And then since, well, really from the strike, from that junior doctor strike, we've seen a big improvement in handover times and flow within there. So our performance is measured in 3 areas. We have the ambulance time to get to the call, mainly around category 2 calls. So the standard is 30 minutes. Within December it was 46 minutes for Yorkshire, but 36 minutes for West Yorkshire. West Yorkshire generally performs better than the other 2 ICB areas. One area that I'm really, really proud of is our 999 call handling. I think some colleagues probably recognise that we had lots of problems over the last few years around answering 999 calls in a timely way. Over the Christmas New Year period, our average was 10 seconds answered, and that compares to 77 seconds last year. That's a really big improvement, and from a patient with a clinical risk perspective and from an experience point of view, that's really, really proud of that. That was also replicated within 111. We saw some big improvements in call answer times within 111. The average was 1.5 minutes, and it was 14.5 minutes for last year. So generally, a real improvement across the board within there. Some of the things that's helped our performance during December and into January has been our ability to use UCR and other alternatives more than we've done before. Just looked at some figures this morning. In January last year, just 188 in December, so in January last year, there was 188 patients who were pushed from the 999 into alternative systems. In December, it was 1,080. That's really, really, I mean, really, really impressive numbers, though, and we can obviously do a lot more around that as well within there. So Andover, that's another big influence, and West Yorkshire is usually one of the better performing ICB areas, and the acute trust within Yorkshire, West Yorkshire, do very well, and that continued within December. Our average handover time was 22 minutes, which is really, really good. We had one day on the 2nd January at Airedale, and that was 46 minutes, and that was the only blip over that entire period. So it's really, really, really impressive. That really does help. And finally, our conveyance rates to ED. Last year there was 65%. This year there's 60%. So that does make a big difference, and we're still taking more patients to ED, unfortunately, as you can see, because we had a 17% increase in demand, but a low proportion being taken through. I mean, overall, it's better than last year, and it seems to be in a good position currently.
Nick, thank you very much. I really appreciate you coming to join us today, and it's always good to hear that we're performing well in general as a system as well. And I know there's been a lot of work that's taken place in working with colleagues across the system. I know some of your colleagues from Yorkshire Ambulance Service were at the Community Provider Collaborative yesterday, very active in our West Yorkshire Association of Acute Trusts as well, as working with many colleagues around the table. So I appreciate you coming and joining us today.
Thank you.
Can I then just hand over to Hannah? If you just turn your microphone off, Nick, that allows Hannah to speak. I've got a list of people here, and I'm really going to ask you to just make very brief comments. We've got Hannah, Becky, Fatima, Tom, James, Majid, and then Anthony will come back to you. Okay, so just ask you to be brief. But Hannah, thank you to Healthwatch for the insight report that we've received today on this.
Thank you. And I suppose just to say, normally before each board meeting, we would do an engagement session with board members to bring people's experiences directly to inform the focus on session. But for this one, it didn't seem appropriate, but we didn't want to not bring people's experiences about how it felt during winter. We've always wanted to do that with these winter planning, but haven't quite got there. So it's good to be able to bring that insight. And I should say that has come from local places, insight teams, local Health Watch, and via West Yorkshire Voice. So it's a very brief report, and hopefully people have read it. Just to pick out some of the interesting insights from how people felt going into the winter. I think there was a worry about NHS capacity, and would support be there. People didn't want to be a burden, so actually they might need to access support and weren't accessing support, which I think is an important and worrying message. People with pre-existing conditions were worried about the winter and how that would impact on their condition, and again support potentially not being there. The impact of winter on people's finances and accessing services, even accessing services, the cost of transport to get to appointments, or the cost of paying for services that are not free, like dental services or other services that people having to make really difficult choices particularly because the increasing costs of heating and staying warm, or making difficult choices. It's not in the report, but it's a really obvious one to bring out, that impact of operations being cancelled, and as Mel has said, the human impact of that, particularly if people have been waiting for a while. The impact for some people that winter has on loneliness. We've already heard from people, particularly some older people, post-COVID who feel nervous about coming out, but that impact of darker nights and the winter, and that impact on loneliness. And it's been referenced several times, but again, winter and the impact on mental health for many people around winter. And I suppose that can all those pressures and all the pressures that you've talked about here, although it sounds like things have been much better, but often those pressures play out in the impact of unpaid carers and any gaps in service provision or challenges in accessing services are particularly felt by unpaid carers. Within the report, we did just put some recommendations around that. So a really big focus, and this will be an ongoing theme from us and always has been, about how communication with people, patients, service users is absolutely key. Robin referenced the work around collectively in Calderdale around that, but getting really good information to people about when services are open, and actually doing that in a kind and compassionate way, not making people feel like they're doing something wrong by trying to access services is really important. Highlighting the support that's available in terms of cost of living. There's lots of support there in terms, but making that support available. In terms of loneliness, there's lots of community support out there, lots of groups there willing to support people, but again, that real focus to get the information out there to people that need it, and just and including on that the promotion of how to stay well with your mental health during winter, and then just finally that focus on the support to unpaid carers during winter. Are we doing that as a health and care system? Is that one of the actions that we should be considering during every winter? That actually we need to put a renewed focus on ensuring that unpaid carers get the support they need during winter.
Thank you very much. And this was a theme from our visit this morning, wasn't it? So I think that is something to take into winter planning and the learning, as well as into other elements. Colleagues, I'm going to ask you to be really brief now so that we can make sure that we can keep to time. So we're going to go Becky, Fatima, Tom. So we can do this side to begin with.
Thanks, Kathy. Thank you, everybody. It's fantastic to see the impact and fantastic to see the stories about what's happening at the front door of the NHS, but obviously the hidden pain is really important for us. And I think when we're thinking about lessons learned for next year, the context is going to be very different next year. So the context is going to be all that local authority context. So I don't know how we're going to track that, but I'm hoping that we can track the impact of local authority budgets on things like GP stress and GP appointments and GP access. So I know that we're seeing GPs say that they have the most enormous demand at the moment. I'm sure that's going to go up, and what that might mean for winter pressures. So that's the first thing. How we bring that context in, how we start that early, but also how we track that now from here on, knowing that we have that pressure in the system. And the second thing is that some of the lessons learnt, I suppose, mirror some of the high-performing health systems. Carol, Nick, you were talking about if you put the front door of the NHS, you put your higher decision makers, you get better decisions, quicker decisions, you get people sent home more, you get your complexity. That's an important lesson, and it's a lesson from other high-performing health systems. So how do we best deploy our skill mix when we're going to bring back in elective care? When we need, and where do we best need our decisions, and where should we best play those out? I think that's quite a difficult decision, but we heard so many innovative models this time, so it's the next step of innovative models. But certainly, I think if we could draw lessons from high-performing health systems about where our decision makers should be, I think we'll probably think better about how we manage our junior doctors over that period. Thanks very much.
Thank you. And we're taking notes as we go along, so those are all really helpful in looking into the learning for the following winter. Fatima, Tom, then James.
So I'll speak fast as well as be brief. The first thing, Anthony, is I think one of the particular areas that I'm interested in is how do we ensure that we're supporting people that don't even turn up at the door? So there were lots of lessons that we learned from COVID. How are we making sure that those lessons for those marginalised groups, and I'm talking about people that are homeless, the drug, alcohol dependency, etc., how are we proactively ensuring that we mitigate and plan for them in the future? An offer to support that is I'm the newly appointed SRO for the Inclusion Health Network as part of my role as the Inclusivity Champion. So let's see if we can join up the dots on those and be proactive in the future. The second one is about trust. So if there's one thing we learned from the lessons of COVID, it is the trust that people have within public sector services. And sometimes the message is lost because of the messenger. So are there opportunities that we've got with the delivery of vaccinations to use newer models, more proactive models, to try and address some of this consumer fatigue that we've got with vaccinations? Because we've seen with the numbers that it's important to increase uptake. But what we're seeing is that no matter what we say and do, people aren't coming. So we need to try something different. And I suppose that the final one is, how are we ensuring that all the work the system is doing collaboratively is focused in the right agendas and areas to address inequality? Because I think we're trying to fix everything. And actually what would really help in the future is some focus on specific targeted groups that we know really need these interventions to support the utilisation of the whole system. And that might have a more impact than us trying to fix everything. I'll stop there. There's more, but we can have a chat after.
Thank you. I'm sure Anthony's taking notes as we go along. So thank you. That's really helpful. Tom, then James, then Majid.
Yeah, just really positive to hear January when it doesn't feel like permanent crisis, and I think everybody should take some sort of solace from that, and congrats back to the staff would be really, really nice. I think we also need to be sort of testing ourselves on how much there is cause and effect there. Is there a difference with I know London's been very challenged and their vaccination rates are much lower, so is there a correlation there? Is it because the flu is not quite as significant as it was in previous years, or is there something different that's changed? It also feels to me like the adults side, if you look at the last 3 years, although my DAS colleagues will scream at me, there has been a response from government in terms of recognising they needed to put some more money into social care on the DAS side, on the adult side. There hasn't been that on the children's side. And when I'm looking back at the ranch, it feels like such a massive mountain to climb on the children's side in terms of demand and everything that's happening. That draws me towards, I think we've got to focus on this as a system more regularly. I think focusing on it with public health together, because that's the interface at which the NHS, hits the children's agenda most frequently. And I think there's lots that we could learn from good practice in those areas. And I think there's a real risk to us in what's coming through the system in terms of children in that respect. And then the final point was just we always talk about the staff in terms of the strikes, and it'd be nice at future meetings to think about a more rounded discussion about what it's like to work in the system at the moment. Could we bring the unions in for some sort of discussion at some point? Could we talk about a different narrative than just every time it's like, how are we managing the impact of strikes?
Thank you very much, Tom. That's really helpful. And as you remember, we had a board focus on session on workforce actually this time last year, led by Kate, where we met a variety of people from the system. So we need to go back and reflect on how we do that in future. Thank you. James, then Majid, then Brendan. James.
Yeah, no, thank you very much. So I just wanted to focus on one area, really. And I suppose it's really great to hear what has been going across our places, and I've seen that kind of in my position as well, and how well it's worked and for the reasons why. But I suppose I wanted to focus on that normalisation of what's going on there, and particularly, and I make no bones about this in terms of talking about the clinicians, as I'm here as a clinician as well, is the impact that has for those individual clinicians, whether you're a GP, managing a patient who's in your surgery who needs to get an ambulance to get down to ED straight away, but there isn't one available, and how you manage that as a team in there. Whether you're out as a nurse in the community dealing with a discharge that you're having to manage, or preventing someone from going in there. Whether you're an ED consultant or ED junior doctor in ED there, having to make a decision there, or discharging someone maybe slightly earlier than you might be used to, but into a safe environment. It's that decision making and those individuals making those decisions. And whilst I think some of the successes have been the way we've done that in terms of shared decision making, they're working with them, and working with your colleagues, and colleagues not just in your departments and not just within your your organisation, but actually how we do that shared decision making across the system between the GP and the ED there, between the community nurse and the GP and so forth there. So I think there's some learning there in terms of that shared decision making that we need to kind of pick up on, because actually if we can make, whilst I appreciate it is we don't want to normalise things, there's stuff there that could be business as usual that we can really kind of build on to help us as we go through, whether it's Easter, Christmas, or actually just during the summer there. So it's just a point to take in terms of shared decision making we need to learn from.
Great. And you've hit on another one of Anthony's why it works in West Yorkshire, which is about sharing clinical risk and those clinical decision making, but you're obviously asking us to do more and work further together across services. Can we then go to Majid, then Brendan?
Yeah, just go very, very quickly. So if you look at the Health Watch report, some of the things in there, they've been there previously. If we forecast next 3-4 years, they'll be in there again. So when we're putting these winter plans together, we need to pay more attention to the basics. There's things like, I don't know where to go, how to access it, when it's available. Vaccinations, why are you doing them in a health facility when I can just walk to a community centre? You know, if you do it there, I will turn up. Repeat prescriptions, they take in weeks, which means I might have to go to A&E, etc. So I think for future plans, we really, really need more attention to the basics.
That's really helpful. And I know there is an example in Bradford where they brought the flu vaccinations to their Christmas fair last year and the vaccination rates went up. I don't know how they did at their Christmas fair that's just gone. So maybe that's something we can track. Okay, Brendan, then Sarah, then Karen. Please be brief, colleagues, so I can get you all to a coffee break.
I will be brief, but I feel I need to represent our colleagues, because what we've just done is made this sound incredibly easy, and none of it has been actually. So I think whilst we are in a better position, that's down to some pretty Herculean efforts from our collective people, and I think we need to acknowledge that. Those who are dealing with patients and those who are making the wheels turn. I think the other thing, so the workforce element of this, let's not forget we have workforce challenges across every sector. So the strike action, I think what we've done is something probably very similar to what we did in the pandemic. We have stopped everything else. That's why we've been able to have our senior decision makers at the front door. That is not a sustainable plan without further investment and further training nationally. So there is a long tail to this, because whilst they have been seeing patients in the most appropriate place, they haven't been doing the other things that we equally need them to do. So there will be an impact further down the line. I think the other thing is I would call out, many of our colleagues have cancelled holidays and leave and time with their families over the festive period to cover. That shouldn't be underestimated. And I think, Nick, it's great to hear what we're doing around the conveyancing, and certainly what that feels like for your people who had an incredibly difficult winter, I would say, last year. But equally, the risk is sitting in other sectors, which I think is what we're calling out. I think to the Health Watch report, that's a perspective, but there are other routes that we've sought feedback through collectively on what do our people, what do our communities want. And I think the next step to this isn't just about gaining feedback, it's actually talking to them to say, tell me how we can do this differently then. Because actually how it feels when you're trying to access an emergency service, for instance, in the evening or at weekends, may feel very different to somebody that we're serving to how it would feel to a healthcare professional. So I know what we're collectively doing in the collaboratives is say, tell us what you need and what you want, which to Madge's point then will make it better. I think there's also something to offer an assurance, despite the fact that I think we've acclimatised to industrial action and indeed winter planning, we're not taking any of this for granted. And in each of our provider organisations, there is a significant rigour to quantifying whether any of our patients or our colleagues are coming to harm as a result of the activity that we're seeing. So we are regularly reviewing our mortality and our harm data. Please be assured of that, but it's in addition to the fact that we're in this for the long game. This is only in, I think, the 3rd week of January. We have the rest of winter to get through, and I think we should pay attention to that. And what I would also like to assure the board is that we are focused on patients. This isn't just about our perspective, it's about our patients who are sick. It is winter. And I'm also just very conscious of the poverty debate and the cost of living conversation that we had. Our people are our community. I've said this before, our community are our people. Everything we've discussed today also impacts on our workforce, and I think that's something we need to play into this. But it would be remiss of me if I didn't acknowledge it has been challenging, not to the same degree potentially as other winters, but I need to say that on behalf of our collective workforce.
Thank you very much, Brendan. I really appreciate you saying that. And as you say, we're still in winter at the moment. I know, Anthony, you brought some learning in March last year and then in July. Back to Robin's point about we're getting together to plan early so we can bring all the points shared, including Brendan's, into that. Thank you, Brendan. Sarah, then Karen, and then I'm going to go back to Anthony, and then we're going to finish up on this item.
Yeah,
Sarah.
again, I'll try to be brief. I mean, clearly there's not a specific reference in the paper around mental health, but colleagues have made reference to the challenges within each of the places. Contrary to the perception around the acute sector, as a provider chief exec, this has been my worst winter in terms of demand and the impact, both in terms of harm to staff and harm to patients. So reaching a position between Christmas and New Year of no bed capacity whatsoever, 38 patients in independent sector beds, which were then saturated, and in excess of 13 patients waiting to come in who were unwell. We had incidents of happening in A&E, people waiting 72 hours for completed assessments and then access to a bed. So mental illness doesn't follow weather variations or respiratory infections or slips, trips and falls. What we've seen is just a gradual increase in the complexity and then the length of time to move people on, and then it saturates. And these aren't people that are easy then to find suitable alternative arrangements for. And we've not seen over the last 12 months that you get dips, different again to patterns in the acute sector demand. You get a dip. And one of our wards, which is so rare, not a single patient on Christmas Day had home leave. Because they weren't well enough. And again, all the things that you normally do to put some capacity in the system just were really diminished over the winter. So I think there's something for us to think about when we talk about winter planning. What does planning look like for variation in demand and access to mental health services at the acute end? Because we're still, still wrestling at the minute with very high risk cases and where people are placed, of smoothing risk across the system rather than being able to eliminate it.
Thank you, Sarah. That's a really, really helpful perspective. Karen.
Thank you. So I want to shout out to our colleagues as well who are supporting people in the places that they want to live and thrive, and are out in the snow and the rain and the everything. So I think it's important we do that. The other thing I think is really important here is there's an awful lot we can learn from what we've done this year. So I'm thinking about the conversation we had at the Community Collaborative yesterday with Rachel from the ambulance service, who was talking to us about some of the data that's been gathered that can help us in the Community Collaborative decide what we need to do.
Okay. I'm so sorry. Just to add gravitas to the comment, really.
So we can make things happen differently in the future using the data we've got collectively. And the other thing I'd say is that the work that the team have done through urgent and emergency care programme board, but also discharge team and the place work that's happened, has really made some shift, and the dialogue happen between us also. Just to say that too.
Thank you very much. I think the air conditioning is affecting some people here. So the purpose of having this report today fulfills a number of things. One, to give you assurance, and I hope you've gained assurance today that we're meeting NHS England requirements. To also highlight to you that we have local priorities by place, and you've heard from place leads around the table. You've also just heard from sector leads representing our provider collaboratives as well. Also to identify learning that is being applied right now, as well as learning going into our winter planning for 24-25 as well. So my question to you, Anthony, yesterday was, why does it work in West Yorkshire? But and some of your colleagues have already started answering that question, which is great. But if you just reflect on that and just summarise what you've heard.
Yes, thanks, Kathy, and thanks everyone for all of those contributions and insights. I felt really rich in terms of what we've been able to take out of the experience of recent weeks. We scheduled this item for this time of year expecting things to be as challenged as they were last year, and I think what we're hearing is in most sectors that hasn't been the case. So I think we need to acknowledge, in a sense, we're lucky not to have had the peaks of flu and COVID concurrently that we had to manage last year, and other infections. But I think there are also aspects of all of the work we've done over the last year, which you might characterise in Harris's terms as the West Yorkshire way. You know, all of the work we've done in starting early. People have said that a number of times. I think genuinely strong partnership working across each of the places and across each of the provider collaboratives has really borne fruit. I've scribbled down a long list of pieces of learning, which I won't try and summarise just because of the time. But I think there are some genuine issues we can take out of this. But I thought Sarah's points were really important about this hasn't been the same experience for all sectors. Mental health genuinely has been under exceptional pressure and remains so. That isn't a seasonal issue, but it is something we have to factor into seasonal and ongoing planning, and we'll look to see how we can do that. So I'll just say thanks to everyone for all of those contributions. We will translate this into a lessons learned review and make sure we incorporate it into the ongoing work, and we will no doubt soon be back into planning for next winter. So thanks everybody.
Thank you very much. And when you came to talk to us about 9 months ago, there was something Bev, as our Director of Nursing for the system, also pointed out, that this helps us learn at moments of surge throughout the year, whether it's a bank holiday, for example, or certain periods in the summer. So thank you for everyone around the table. You've all played a role. Thank you to Lou and Deborah, also have been part of preparing the report. And I feel like there's a lot of thank yous gone around the table, so we can have a discussion, perhaps Ian, Jonathan, Anthony, myself, on how we put a thank you out to the whole system as well. It's particularly Brendan's point as well about what people have sacrificed over a period over the last few months as well to make sure we've got safe quality services. I'm going to finish up now because I want to make sure we've got a break.
It was just to add to the thank you, because going back to Hannah's point, it would be great if we could thank our unpaid carers as well, who we do see as part of our collective workforce, and that token of appreciation would mean a lot.
Thank you. I think there's a theme there on how we work with unpaid carers throughout this planning as well. Thank you, Fatima. So we're going to take a break now in our meeting that is being live streamed in public, and we're going to take a 10-minute break, and then we'll come back afterwards to look at our board assurance framework, risk register and dashboard. Thank you. Welcome back to the next section of our NHS West Yorkshire Integrated Care Board meeting. We're here in Wakefield today, and we've just finished a discussion before our break on winter planning and our learning together across our 5 places and services on what's working this year, where we're improving, and our learning to inform the 24-25 winter period. We now have a section on risk. Colleagues around the table, you have our board assurance framework in item 7, looking at strategic level risks across our system. You also have our risk register, looking at more week-to-week, month-to-month risks across our services and our places. So I'm going to ask Laura to give us an overview of both. And we also have our integrated performance dashboard in item B, as a reference as well. So colleagues, first of all, we'll look at the strategic level risks, then we'll move into operations, taking 8B and 9 together. So Laura, would you give us an overview, please?
Yes, thank you. I'll keep it brief by way of introduction, and then if people have any questions. So as you know, we committed to bringing the board assurance framework, the BAF, back to this meeting, and we've been working over the last few weeks focusing on updating the heat maps. So that's the scores that you'll see within the BAF for both West Yorkshire and at place level, and starting to populate further the mitigating actions, again at both West Yorkshire and place level. You will see that we have a new risk that's been added around climate change. That's still in development, so we will be working with places more closely in the next few weeks to fully populate that. And you'll see that there is a cross-reference over to the risk register report, where it's come off the corporate risk register and moved on to the BAF. And we'll also be removing the risk that's in there around the pharmacy, optometry and dental delegation, as that's a risk that has now closed on the BAF. It does remain work in progress. Risk owners are now focusing on completing the work on action, so we've still got some more work to do on that, and that will come as an overarching action plan to the next board meeting. And we also need to do some work to link it to the risk registers, both at a corporate level and at place. Again, we're doing that over the next few weeks. In terms of next steps, just to give you some headlines, it is due to go to the audit committee at the end of this month. The February West Yorkshire committees are going to spend some time looking at it, and particularly looking at areas of difference, whether we have any outliers. We'll try and get underneath some of that, looking at those heat map scores. And we will be using the BAF to help develop the business plans and also making sure that it's linking with the development of the board and the committee work plans for 24-25 over the next few weeks. I think that was all I was going to say by way of introduction. I'm happy to take any questions or comments.
Great, thank you. And just a reminder to colleagues, our board assurance framework links with our overall strategic plan, which is overseen by our West Yorkshire Health and Care Partnership Board, our ICP, Integrated Care Partnership for our system. And what you can see there is a number of elements. So I just wanted to invite Ian, who leads on our strategy for the system, and also whether, Ian, you've got any comments on the inequalities section, particularly where we have one of the highest scores there.
Yeah, thanks, Cathy. So I guess the starting point is we've deliberately tried to fully align the BAF with the integrated care strategy. We've got the 4 purposes of an integrated care system, and the 4 sort of headings of the integrated care strategy align directly to those. So we've tried to do it in that way. I think another example of how we're trying to tighten up that alignment is we've included the climate change risk, which is ambition 9 in the 10 ambitions of the strategy, as a strategic risk, which is a better place to put it, to be honest, rather than one of the sort of more detailed sort of corporate risks where it was sat previously. So it's fully aligned, and you can map it directly through from those strategic risks to the 10 big ambitions in the ICS strategy, and that's really important. In terms of, I think it's risk 1.1 you're referring to, Cathy, which is our priority 1 around narrowing health inequalities and the risks to that due to wider social, economic and political factors. I think that's so high, exactly for the conversation that we had under the Chief Exec's report, where we were talking about pressure on local authority budgets, what that will mean in terms of the difficult decisions that local authorities are going to have to make, the implications on that on the voluntary and community sector, and actually the fact that achieving those ambitions on health inequalities are absolutely a system and partnership endeavour, and it's not wholly within the gift of the NHS. So that's why it's flagged so highly, really, because of what we've observed in the last couple of years, particularly around the financial position in health and local government, and that's why it's remained at that level.
Great. Thank you very much. And something we've discussed along with Rob, our Chief Exec, is on the focus on sessions for us as a board for our 24-25 period, having a focus on tackling inequalities particularly, which encapsulates lots of things that have been talked around the table today, including, I think, a point, Majid, you made earlier about focusing in on certain communities that are disproportionately affected or can't access services. Jane, I know you want to come in and particularly interested in your views as audit chair, but Jonathan, the other one on our board assurance framework that stands out is around that statutory duty on delivering in effect a balanced budget. We're going to talk about this later, but just any reflections now when we look at it at a strategic level for our system?
I mean, I think I will come on to it later. I think the non-recurrent measures that were covered in Rob's Chief Exec report to the board earlier sort of set out how I think we should be on track to deliver a balanced budget this year. But next year, for the conversations that we had before, is a different matter.
Thank you very much. Jane, as audit chair, just your views as well would be welcomed, and then we'll move on to the next section.
Yeah, thanks, Cathy, and thanks, Laura. I think it's quite interesting. The way I've been looking at it is like looking at sort of where our current score is against the target, because obviously we have different targets reflecting how we approach these different risks and where we want to be bold or cautious, etc. So there are about 3 or 4 where the gap between current and target is significant and therefore needs significant action to sort of bring us back down to the target. There's a couple under section 2, managing unwarranted variation, and then again in section 3 around using collective resources wisely, and obviously 3.2, 3.3 got significant gaps to close there. When you get into the detail behind it against each one of those, Jonathan made comments earlier about the sort of need to think differently in the new sort of financial climate that we find ourselves in, and is going to continue to be challenging. At the moment, when I kind of look at the sort of mitigating actions and controls, it feels quite steady state, old school responses, and it doesn't yet pick up, and it feels as if that's not going to be adequate to close those gaps. So I hope through the work that Laura said is ongoing, when we come back and look at this again in more detail, it'd be quite interesting to see about some. I think we need bolder actions. As I said, I think Jonathan alluded to that around finance and resources. If we are really planning to sort of deal with this, and I think it will prompt some different and difficult conversations, but probably ones that we need to have. So I think that's where I would focus the work in the next few months particularly, as well as obviously the links into the risk register that are in some cases not there yet. Thanks.
Thank you very much. And those points on strategic choices, any radical change, and what the evidence of bold, if that's the risk appetite. Okay, I'm going to leave it there. Laura, is there anything else on the board assurance framework? No, I've really found the overview across places as well. I printed it off. I've got it for a record as well. I think this is really helpful, as well as how it connects with the system, which is how the risk both for our board assurance framework at strategic level, as well as corporate risk day-to-day, week-to-week, month-to-month, the way that we look at that both overall and in place is really welcome. Thank you. Just something I forgot to mention earlier, but it came out of the partnership board, was about the Fair Work Charter led by West Yorkshire Mayor Braben as well, about an opportunity for us to consider together. And I think this is one of the things around the fourth purpose that you can see, section 4 in the board assurance framework might be something for consideration, as well as other opportunities, including health tech, Majid, that you picked up on earlier. I'll leave it there for now. But one point, sorry, there is one more point. There's something on the outcomes framework that needs to come out of this, and that connectivity back to the partnership board, because certain section, each strategy, each sub-strategy out of that, the 10 big ambitions, is coming to our partnership board, but this board assurance framework links with that as well. So we just need to do some more work, which we talk about regularly, and about the connectivity between this board in terms of NHS commissioning and the West Yorkshire Partnership Board as an oversight on strategy. I don't know if you want to comment on that.
You've got 2 seconds. Really.
Yeah.
Yeah, just to say, we'll pick this up under the private session. One of the big priorities for the refresh of the Joint Forward Plan this year is getting a really solid outcomes framework that's relevant to the NHS part of the system that can impact on the 10 big ambitions. So that's absolutely clocked and a priority for the refresh of the Joint Forward Plan.
That's great, and that came up at the Community Services Provider Collaborative yesterday as well, as how we take an outcomes approach. And our colleague Jo Webster from Wakefield talks about that as well in primary care commissioning, which I think is really welcomed. Okay, thank you. What we're going to do now is take item 8B, which is our integrated performance dashboard, where you can see elements of service performance. You have a section on people there, on workforce, and a section on finance, and we're going to link that to the risk register. So first of all, Anthony, is there anything to highlight in item 8B in terms of the system performance dashboard?
Thanks, Cathy. I am very conscious of the time, so I'll assume members have read the report, and I'll largely leave it at that. But just to note that this is the version of the report that includes an update on the 10 big ambitions. So that happens in every other meeting. Also to note that we've now included some indicators on dental activity, which we haven't had before. So I think that builds on some of the discussions we've been having here before about some of the risks and the opportunities around looking to make improvements in access to dental care. I know we've had a lot of comments in previous meetings around suggestions on what we might add to the report or how we might improve it, and we are going to take those forward into a review of the dashboard for the new year starting in April. So if I can suggest we perhaps try not to get into too much detail today on content and format issues, but happy to take any questions on aspects of performance that colleagues want to pick up.
Great, thank you. And I'm really pleased to see further reporting on primary care, particularly GP services, and also virtual ward capacity as well, which was really welcomed in taking forward. Jonathan, is there anything you want to add on the finance, and Kate as well? Is there anything on the people side? No. Okay, so we'll just come on to the finance. Jonathan, is there anything you want to highlight?
Thanks, Cathy. There is. So this contains the report as at month 8, so the November position that we reported through to NHS England. Just to draw the board's attention to the fact that we did report a balanced forecast against our balanced plan at month 8, which was a change from the previous position that we reported through to board. As I said earlier, we've maintained that position for our month 9 forecasts, subject to those additional costs incurred through the December and January industrial action that's happened. The only other thing to draw to the board's attention is that our agency spend helpfully continues to be less than the cap set by NHS England, and we are still on track to deploy all of our capital in 23-24.
Thank you. Laura, just on the risk register item 9, is there anything you want to highlight? And then I can open it up to comments and questions. Becky starts off, then Harris. So, Laura.
Yeah, thank you. Yeah, just briefly, I just wanted to give some context for today's risk report, because it looks like there's a lot more movement than you would normally see. And the context for that is the work that's taken place this cycle on static risk scores. So you'll remember we said at the last meeting that we were going to focus on any risk that had been static for 4 or more cycles, so that's 8 months or more. So everyone who's a risk owner or a senior reviewer for those risks has met with myself over the last few weeks, and that has resulted in quite a bit of change. So there is a summary, there's an appendix that summarises the changes that have been made as a result of that. Some of it is because things have moved on to the board assurance framework, as we talked about one of the examples around climate change. We've also seen some closure of risks and then opening of new risks. We had some risks that were very wide-ranging, and we felt it was better to split those down to enable better management of them. We've also identified some that had really become issues rather than risks, and so we've moved on to think of what are the risks that emerge from that becoming an issue. And then there was also one, I think, that had reached tolerance, so we closed that. So it was a really useful piece of work to do. We will continue to do that as risks hit that 4 cycles or more as we go forward. But I just wanted to give that context, because it does look like we've got a lot of either new risks or risks that are closing, which might look a bit unusual. Thank you.
That's really helpful, and if anyone's interested in why we look at that, it means that we need to pay attention to things because people have flagged them as risks, and then we need to make sure mitigations and actions are taking place. So we've got comments and questions, first of all from Becky, then Harris. I don't know if anyone else wants to comment, just let me know. Becky.
Thanks, Anthony. I do understand that you're coming back to this, but we seem to be coming back to this in the future so many times. So primary care. I don't think I can tell from these metrics what good looks like. So when I look at appointment system, I see Kirklees has got more face-to-face, but less telephone and less home visits, and Leeds has got less appointments overall. And yet, apparently, everybody is in line with recovery plans. So there's massive variation, probably about communities and probably about the relationship between general practices and their populations. But actually, is that any good or not any good? So I can't tell from these metrics whether we're doing well or not, except that we're apparently meeting some performance requirements that mean that we can have massive variation. So that's, for me, that isn't very helpful. I don't see anything on inequalities, so I certainly don't know who isn't getting primary care access at all across the system. Back to Madge's point, and I'd be concerned about that. Our hidden populations really matter. It's really difficult to know about needs, so I'd expect from research that where we are offering less but good quality appointments, we know that on some continuity people are getting better, so they have better health outcomes. But we're just looking at numbers of appointments because NHS England wants us to, and I don't think that's the right metric. We've said it's not the right metric here a lot of times, but it's still the metric that seems to matter here. So we really ought to have something on continuity around complex needs, because we know it helps meet needs and we know that people benefit from that. So why don't we? The patient satisfaction has no narrative on it. We had good narrative at the last board, but that's not included here. And actually, I asked if we could have it as a trend. There's no point when you look at it on its own. It has to be year on year. Wakefield, you demonstrated the variation in terms of it improving by 10%, and there was a really good narrative about why that was. Bradford's down, Calderdale's down, and there were some narratives about that. It would be good to have that in here. It does, on its own, as a static, it doesn't matter. So that's the first thing. Second thing, hospital performance. We've got lots of metrics, but we don't have a story about each hospital. So you could have, so it was really interesting, Mel, to hear what you were saying about the impact of RAC on Airedale's performance. It's not in any of the narratives against any of those little metrics because it's an add-up one. So if Airedale is struggling on the 4-hour wait, if it's struggling on bed occupancy, if it's dipping on cancer weights, day surgery, outpatients activity, C. difficile, that's a whole thing. What's the answer around that? So if you look at each individual thing, you can see little bits of stuff. But it probably isn't about little bits of stuff. It's probably something more about some issues at Airedale that are being addressed in a different way, and we don't see that. So I would welcome something in the hospital performance, which is about each hospital in the round in terms of all of its. Same with community and mental health services. I'd say the same issues. And then when we talked, we talked earlier on about what we're going to publish around children and young people's services. And we're saying that we're doing well. We've got 1 contact a year in children and young people's mental health services, but we're about to put a statement out saying it's a real problem. That feels an absolute disconnect for me, probably because there's loads of kids not getting stuff. We don't feature that at all. I think I've asked for that before, which is we may have this number getting 1 contact, but if there's this number out there, it doesn't matter that we've got this number getting it. I'm really worried about this number out there, and I'm guessing that's what's driving the statement we're about to put in about the impact on children and young people's mental health. So there's a disconnect there. We would get some scrutiny back on that publication we're about to do if we don't have it right here. So I'd like to see that. Thank you.
So I think there's some messages there on better connectivity, trends, a narrative, and oversight in connecting it back together. So we're not fundamentally changing the framework of it, and that connectivity between something that's in a statement or something in a report that comes back to this dashboard as well. So, okay, that's fair being a critical friend to this piece of work. I think, Becky, particularly in your role as the Quality Committee Chair, if we can take that out of this meeting then as an action, Anthony, for you to talk with Becky. And I know what you're driving at is you're striving to make sure that we're reporting in the best way, and we've talked before about we pay attention to the things that we measure. It's what we do in the NHS, and the tension we have that we need to deliver here is we have NHS England specific targets that we need to deliver, as well as we're putting our own local priorities together, as you could see in the winter planning, for example. So it continues to be work in progress, but thank you, Anthony. I'm going to go over to Harris next. Then I can see Fatima with a hand up. Then Richard. Welcome, Richard, as well. And Majid. So Harris.
2 points. The first one being on Yorkshire Ambulance Services workforce. I remember it was at the board meeting in Bradford around about a year ago. We discussed 999 and 11 call handlers. So Yaz's long-standing recruitment challenges have been on the board's lens for a while. So what approaches have been done in that time, what adjustments have been made, and what's working and what isn't? I suppose this question is more aimed at Kate. And also, through an inequalities lens, Anthony, would it be possible to look at the stats more, so who's waiting longer in elective care? Is it BAME people, is it younger people, and through all the stats, maybe specifically zooming into one every few board meetings, so we know who's it affecting the most?
Thank you, Harris. That's links with then the inequalities work that I'd like to focus on. I don't know if Kate, if you've got a response tool, then we'll come to Anthony, and then we'll go over to Sarah, then Richard, then Majid and Bev. I just wanted you, if you did comment on the section of the report on maternity and neonatal services, I'd welcome that. We're keeping on with the list here. So Anthony, and then we'll go over to Sarah. Oh, sorry, Kate, then Anthony, then we'll go to Sarah.
Well, firstly, I think James is offering to reply because I think he might be closer to some of the
right.
agenda. I mean,
shall we go to James,
Harris,
then?
more than happy to get some of that detail. I mean, you're aware of some of the work that's happened around entry-level qualifications and requirements, one of the things that you're quite proud of yourself. So, but in terms of actual detail of each of their recruitment pathways, I'd be happy to discuss that with you, but not got that detail obviously in front of me. But James might wish to comment. Thanks.
Thank you, Kate. Over to James.
Yeah, I'm not going to be able to go into all that detail here, but it's just, I suppose, from an assurance point of view, it's just to kind of, I mean, so throughout last year, we had regular meetings of which workforce, was regular meetings with Yaz, because we're the lead commissioner for Yaz, Yorkshire and Humber, as an ICB. So we had regular meetings, actually chaired by Rob Webster, and one out of those regular meetings, weekly meetings, which was every 4 weeks, was related with workforce, understanding the new things that Yaz were doing in order to be able to recruit people, maintain people on there, and looking at the results from them. So we did, on a regular basis, those meetings were stepped down there, recognising we'd come to a point where we didn't need to carry on with them at that point. But there was that assurance given at the time in terms of what they were doing and some of that impact. I still think there are challenges, as you would recognise, in terms of that. So there is, just to give you that assurance.
Thank you, James. Anthony, is there anything to reflect on? Then we'll go to the next round of comments and questions.
Yeah, I mean, thanks for all of those comments and suggestions. I do recognise the limitations of the data we're reporting. I think some of those limitations are features of the fact that we don't necessarily have routine data on some of the detail, but that doesn't mean we can't do some deep dives. And as Harris was suggesting, we can perhaps bring specific reports to specific meetings, can't we, rather than try and build everything into a single dashboard. So I think we'll have those conversations outside the meeting, as Cathy suggested, and see what we can take forward. So really helpful, thanks.
Great, thank you. If I ask colleagues to be brief in their contributions, we go Sarah, then Richard, then Majid. Sarah.
Yeah, I think it's really hard to present data which is going to be most beneficial to the board. So if you think about the metrics that are in there on relevant to mental health, it's really small, it's really narrow. I've got my trust board next week. We'll have a whole comprehensive data set on a whole different set of metrics along the pathway from response times to crisis calls to A&E departments to how long it took to pick the phone up to what the outcomes were for people. And that'll have been through a level of assurance and scrutiny at our subcommittees and where there's a need for a deep dive. So activity around early intervention, the committee requests a deep dive on that shows what a performance improvement trajectory looks like or what's going to get in the way. So in effect, that's where a lot of the detailed work takes place. So it's the role of this board to see and just be assured that that takes place, because there's such a time lag with the data as well, which I know is a constant challenge with NHS England. When I sit in meetings with the regional team on the mental health metrics, they're always, the latest I can get on out-of-area placements for the region is November, just because of bizarre ways in which NHS England processes data. But I suppose what my feedback to the non-exec members is, all of this gets discussed in a huge amount more detail, every public board meeting and every subcommittee. And so it's how do you get assurance that those are in place, rather than asking questions that have probably already been answered 3 months prior.
Okay, thank you. So that better connectivity with provider board oversight. Thank you, Sarah, that's helpful. Richard, then Majid, then Jane.
Thank you, Chair. I mean, I agree with Becky Molby sort of on the primary care issue. I think we should take it as read that the data that we are collecting around primary care is not of useful nature to assess the quality. And I think we've said that repeatedly, and I think we'll go on saying that whilst we're required to do that. I just wanted to comment on the NHS dental data, the proportion of adults, which is about 43% of adults having seen a dentist in the last 24 months, which means 57% haven't. But that seems a very flat line. I know that we have made some investment in dental services. Would we expect that line to go up as a result of the investment that we've made?
Thank you, Richard. I'm going to hand over to Ian.
Yes, Richard, we would. And so, I mean, I guess the first thing I should say about these three sort of data sets that we've included is that they're not perfect and they don't meet the test that we've been talking around. You know, does this reflect need? Does this reflect inequalities? How does this play out across different communities? But we still think it is useful data in order to show the overall sort of position across West Yorkshire. We'll work with the commissioning team to see if we can dig into this a little bit more and get some of those variations. What I would say is that, as we discussed in the board meeting in May, we inherited a really challenged position on dental. You know, in terms of you know, the contractual position, the workforce position, the funding position. I think what you're starting to see in those yellow lines is a small degree of improvement. So if you look at the children seen in the last 12 months under 18, it's gone up from 55% to 57.3%. It's almost 2% in 6 months, which isn't huge, but it's in the right direction. The adult cohort, and there's obviously a lot more of them, we've seen that it's gone up from 43.1 to 43.7. We're at about 82-83% in terms of value of contract delivered, which benchmarks pretty well against national under the North Eastern Yorkshire systems. So there is a gradual improvement in the first 6 months. The schemes that we agreed in May were implemented between the summer and sort of the last couple of months. So the schemes, for example, that we've just recently put in place around children's access to dental services, we wouldn't see that starting to impact until the last quarter of this financial year. So the way I read it was that there's been, you know, modest improvement over 6 months as the schemes impact that we agreed in May. We'd expect that trend to continue in the right direction. We are delivering more a higher level of contract activity, and we are delivering to more children and adults than we were when you took on the service in April.
Okay, thank you, Ian, and we'll continue to track that as a new metric being reported. So we're going to go to Majid, then Jane, then Fatima, and I'll ask Bev to give us an update on maternity services, and then Anthony. we'll come back to you. So Majid.
Yeah, without sort of labouring the point too much about health inequalities, we've just seen the board assurance framework, high likelihood, high impact, but when we're looking at these, the data here, we don't get a feel of, is it improving, what's at risk, where are the biggest challenges? So in the next iteration, be really good to focus in on that. The other thing, just looking at the people sort of statistics and looking at Leeds and York partnership, it's got almost double the turnover of staff when compared to others. And similarly, when we look at the sickness in Leeds and York partnership, it's amongst the highest. So it'd be good to get a feel or some feedback back from the place on that particular, just as to what is going on over there. Because it's almost double the turnover, particularly at 20%.
We have the chief exec of that trust here, so don't know. So
yeah, that's not. I don't know. It's come up a couple of times that it's not accurate data. Our turnover significantly lower, so I need to check back again why there's a glitch in the data that we're reporting to our trust board is not accurately reflected in the data that's coming back here.
Okay, thank you, which reiterates your point on connecting the two. All right, thank you, Majid. Jane, then Fatima.
Yeah, thanks. I was moving on to the risk register, if that's okay. Much thanks to those of you who've been involved in that review of some of those static risks that Laura alluded to, and I can see kind of the logic of many of those changes. It feels appropriate. I guess I would ask that, we didn't, ideally that shows the kind of level of ongoing review that should be taking place. So I don't want people to think that's like, okay, we've got it back in order now, but if we can keep reviewing on that basis, because this one should be, quite, changing as we respond to things, because it is more sort of hopefully operational and in our gift to influence. I guess and I know the places have done a similar exercise as is seen in the report. When you look at the summary across the places in terms of the grading of the different risks, and you look at the critical column, there are a lot in Bradford still, and I think you mentioned one that's going to go even higher. So I just be interesting to think about how we pick up any deep dives around sort of the risk profile in different places and reflect on that, or look at triangulate that with performance data, finance data, etc. But I think sort of seeing the starkness of the acuity of some of the risks in Bradford at the moment, I wonder whether there is some sort of deep dive that we'd want to do, or triangulation for Bradford, just so that we're all sighted and feel as if we're kind of aware as to why things are where they are and whether there is more we can do to help as a system.
Thank you, Jane. Laura, if you want to briefly respond.
Yeah, I think it's a good idea to do some more details. I think the things I would just say, and I don't want to speak for Bradford, Mel might want to comment, but I think the places have been doing the work around the static risk scores, but some of that is not yet reflected in due to the slight time delay, which hopefully will be sorted with the new governance cycle. So I do think there'll be some more movement, because I know there's been a lot of focus in Bradford Place around that. So it might be worth letting that play out and then look to do a deep dive, if that's okay.
Yeah. Okay, and Mella's place leads nodding as well, so we agree to that. Thank you. Okay. And there's also a theme around deep dives into inequalities, who's waiting longer, who can't access services, a theme there. Fatima, then Bev, then Anthony, and then we'll conclude this item.
So just a couple of reflections, Chair. I think the first one is Anthony and I have already had a bit of a conversation about how we can look at the data through the lens of inclusion. So that's something he's already mindful of, Becky, and we're going to start to explore how we can utilise the expertise within the partnership to address that. The other thing I was thinking when I was reading this, and I've not looked at it for quite a while, so sometimes having a fresh pair of eyes is really helpful, is some of the metrics that we're using to demonstrate our movement towards the 10 system ambitions. And I'm wondering whether we're using all the data at our fingertips. So now having a foot in the West Yorkshire Combined Authority, we've got access to different data. And I was just thinking of things like, the obesity data that we've got, or the economic prosperity data. Obviously, having a business board will have data that will be different to what you've got access to, and it might be sooner. So I'm proposing, she says, a task and finish group maybe to support that we can bring in people from WICA from. My two questions were on the system ambition regarding the antibiotics, because it caught my eye, mainly because I've had some recently for respiratory infection. why we're slightly above the average, although I understand the trajectory is going in the right direction. And then the second one was about maternity, which I think Bev's going to speak to anyway, but just sort of the narrative within that and some reassurance that we're going in the right direction.
Fatima, you've asked a question where I'm just about to try and identify who can answer that for me, and I'm looking towards James. Yeah, okay. Let's go to Bev. Thank you, Fatima. And I think that connection with West Yorkshire Combined Authority, WYCA, would be really welcomed. As you know, we signed a formal partnership with them in September last year. Mayor Braben and the Chief Exec of WYCA came to join our partnership board meeting in December. So it sounds like a good time to then start looking at connected data. Bev, could I come over to you, please, just to give us an update and a look ahead also that you're going to provide a written update for us at the next meeting?
Yeah. Thanks,
Thank you.
Chair. So this is in relation to the risk around delivery of safer maternity and neonatal care due to staffing levels. And I think I've reported to this board previously that whilst the vacancy gaps for midwifery, not maternity services, midwifery, so that's just one discipline, whilst is improving significantly across all of our provider organisations, there is still a high level of sickness and a high level of maternity leave. We, at the LMS board that we meet on a monthly basis, we look at gaps in services and risks in services and in disciplines, and we've got a real kind of deep view of all of that and what we're doing to retain staff as well as to recruit. So that's one thing. However, I do want to address the delivery of safer services, if I may, whilst you've given me this opportunity. So there's a couple of things to mention. We've just completed all of our peer visits, so the board will be aware that one of the recommendations a couple of years ago from the Donna Ockenden report was that there were visits to each provider of maternity services across the LNMS to look at their progress against the immediate essential actions and any actions as a result of safety concerns that they may have in their services. We have just completed, actually last Monday, the final visit. That organisation was Airedale. They will receive their report within the next couple of weeks. What we will do then is we will collate all of the information from across the system, look at common themes, any actions, and also learning across the LNMS. The other thing to mention is we are currently, the provider organisations are currently signing off their maternity incentive system returns. So for board members or people that are watching who do not know what maternity incentive scheme is, it's a series of 10 safety actions designed to improve delivery and best practice in maternity and neonatal services. And I think it's fair to say, and the provider chief execs with maternity services will back me up on this, is they become increasingly difficult as years progress. And there is a financial, they say a financial incentive to achieving these. We are halfway through signing those off. I think that it's February is the deadline for those. We've currently signed off Bradford, who will be declaring compliance against the 10 safety actions. We've also today actually signed off Calderdale, who again will be declaring compliance against the 10 safety actions, and Leeds and Airedale are in the diary in the next week. I think in addition to that, we have the maternity safety strategy, and that's to halve the rates of stillbirth and brain injury by 2030, and that is really, really challenging. We saw a deterioration in progress against that during COVID, and we are now starting to improve again, but we are behind trajectory. We're not on our own as a system, but we're putting actions in place to try to address some of those. We also have the Ockenden immediate essential actions that we look at on a regular basis and assess each service against. We've also got CQC action plans, and maternity services have local action plans. All of this comes to the to various meetings of the LNMS board and is fed up to the regional maternity transformation board. So I think it's fair to say, out of probably any service that we have, this is possibly the most scrutinised. There is a plan. I've been invited by Cathy to come to the next board in March to give some real detail of some of this. So we will look forward to hopefully reporting that everyone's signed off their MIS submission, and that they've all completed the 10 safety actions designed to improve delivery of care. What I would say is, in particular, as a result of the industrial action, and we've talked about that quite a lot today, one of the things that we really struggled and we escalated at regional and national level was that potentially we wouldn't be able to achieve some of the safety actions around multidisciplinary training because people were either under industrial action, and it's got to be multidisciplinary in the provider organisation. But thus far, both of the providers that we've signed off have achieved that, so kudos to them. I'll leave it there. Thanks, Chair.
Thank you very much, Bev, and I appreciate you taking the brief for that report in March, and I'm inviting Becky as our non-exec maternity safety champion to support that report coming through as well. No, I've received anecdotal feedback on your visits from providers, and they're very positive about the visits that have taken place to maternity services. James, I'll just come over to you to answer the other question from Fatima.
Yeah, no, so thanks, Fatima. In terms of the AMR, so I suppose there's lots going on across all different sectors, really, and kind of been brought together through our lead in AMR, but there's actually working with all the leads within our hospital trusts, across our community in terms of, and across primary care, and also with social care and the local authority there. So I think there is, in terms of specifics around kind of E. coli and Klebsiella, the specific types of infections there, I think there is a recognition in terms of deterioration there, and therefore there's a bit more refocusing on kind of the strategic approach to that, looking at various areas to try and improve on that, and that's working with our trusts across the patch. Also working between primary and secondary care in terms of understanding specifically things like recurrent infections, specifically around UTIs, but others as well there. And as I said, working with our local authority. So the work is happening. It's quite across our different sectors, but it's also recognising the interaction between our different sectors as well there, and recognising that there is an element of also refocusing on what some of our more severe infections that are being highlighted within the report.
Thank you, James. Appreciate that. Okay, I'm going to bring that to an end now. We are overrunning, as you know, but that is because we had particularly a robust discussion earlier in relation to system working and financial planning across our partnership. The last part of our meeting are our committee AAA reports. The reason to put them at the end today was through our risk reporting, Chief Exec's report, winter planning and performance dashboard. We should have aimed to have covered all elements, and also in the public domain there are those AAA reports to identify what has been discussed within committees in West Yorkshire and our 5 places. Colleagues around the table, is there anything of urgency or priority to share, particularly if you are the place lead or the committee chair there? Is there anything for the board to note? No. Okay. And thank you to everyone who is providing those reports. As Laura talked earlier, we're going to make sure that they, through a new governance cycle, will be delivered in a more timely manner, so there's better connectivity and more up-to-date reporting and information. But thank you to colleagues who are working on that, including in our governance team. Okay, I am going to bring our meeting to a close. We don't have any other business, but I did want to note major conditions strategy will be published in March. So by the time we meet next time, that will have been published, and colleagues, I'm sure, around this table and in our provider collaboratives will be looking together to respond to that. And our next meeting is in Calderdale on the 18th of March. And particularly, we will be inviting questions from the public by the day before. So thank you to everyone who has watched this meeting live, and to those who are watching it on record. All the documents that have been discussed today are available online to download, as well as our online portal for our declarations of conflicts of interest. And thank you for your interest in our work as NHS West Yorkshire. And thank you to everybody around the table for their contributions today. It's very much appreciated. Thank you.